I hope you saw it on the internet, or any one of your emails, but I'm just going to start. Okay, Holly, I need you one more time. I don't know why it quits working. Hey, well, I'm Janice Schwartz. I'm the executive director of PC Project, and welcome. You guys are all my family. I'm so glad to be with you today. Our theme is Stronger Together. And I just need to say, first of all, there's obviously people on this call who are new to PC Project, and there are old friends, and it's good to have you all. When I do this part of PC Project, I always think, oh, what am I going to say? What, that won't bore the old people, but will still be okay for the new people. Well, you're probably, if you've been here before, you'll get a little bit of review. And I just want you to know, over the next few hours, we tried our best to do a program that would answer the questions that you had and when you registered. So just to give you a little history, I am a spontaneous mutation of PC. I have K6A. When I was a little child, you notice I'm sitting up on the bathroom counter because my mom fixed my hair while I was sitting up there. I couldn't stand. And I went to many visits to the doctor. And as many of you will know, I was very lucky because I was diagnosed correctly as a small child. Well, I grew up, married Dave, and with every marriage comes a mother-in-law. And this is important for later in the story. And Dave and I started our family. We had our first two boys that have PC. They had the typical symptoms of PC, the infected nails, or all 20 nails in our case, infected nails, the white tongue, the follicular hyperkeratosis, the ear pain. And of course, as they started to become weight bearing, they got the sore feet, the calluses that made it painful. And as our particular mutation, the more we walk, the more we blister, the more it hurts. And to make a long story short, I was just content to live. I shouldn't say content, but I thought, I'm so rare, no one will ever care about our disease. But my mother-in-law, Mary, said, let's do something about it. And she did. It was my mother-in-law, Mary, that started PC Project almost 20 years ago. Those are my two kids with PC on my side of the screen. The right side of the screen, my two younger kids do not have PC. And that is the short story of how PC Project started. Wanted to just let you know what PC Project is like now. And I always have to show this slide because I want you guys to know that even though we started PC Project, for my two kids, PC Project is more about us. We are a global international charity, and we love all of our patients of all ages. So we don't care if you're 90, we love you and we want treatments for you and we want to help you. So our vision here in 2022 is a day when those who suffer from PC will live without excruciating pain, isolation, and embarrassment. Our mission is we are dedicated to finding effective treatments and a cure for Pachyonychia congenita, a painful, debilitating skin disorder. And we decided we had to put that in our mission because so many times people could not get past what is Pachyonychia. And so we finally just put it in our mission. It's a painful skin disorder. And then they go, oh, okay. Through helping and connecting patients, which is what we're doing today, empowering research, we do a lot of that, and partnering with industry, which is pharmaceutical companies. Just wanted to let you know, some of you have probably started to see this out. We have a brand new logo. We were founded on love. Everything we do is based on love. And so we wanted to keep our old heart, but some people thought we were a genetic heart condition, and we are not. So we wanted to keep the heart to remember that we're all about love, but we're a genetic disease. And also, I hope you can see the feet in there. We want to get the narrative out that PC hurts and it hurts to walk. So that is our new logo. So you've seen it around. And if you haven't, just wanted you guys to be the first to know. Also wanted to let you know that we are almost ready to go live with our new website. And this is just a very sneak peek of it. We're so excited. We'll let you know via email when it goes live, but just to tell you, we're very excited about that. And I wanted to give you guys a sneak preview. I'm not even going to scroll it. This is a screenshot. And I couldn't go too far without just saying thank you to the people who give us their hearts. And every single person on our program today is someone who is a volunteer. And I specifically put Shrikant, he's on this call. He is a PCer. He joined our registry about a year ago, and I can't remember it exactly, but he has helped us so much as a volunteer with our new website. He is super smart. He's got a lot of IT background, a lot of computer skills, and so thank you to Shrikant. Thank you to Holly, who's sitting right next to me. Thank you to all our patient advocates, to our doctors, our scientists. Just thank you so much for the people. PC Project is in large part run by volunteers. So thank you. We have a volunteer that did our new brochure. I just wanted to let you guys know that. I'm going to just go a little faster. I wanted to let you know, I was like, what can I talk about today that someone hasn't heard before? But the main two programs of PC Project, if you don't know already, is we have an IPCC. It's a professional side of PC Project. It's our International PC Consortium that is made up of researchers, physicians, and industry partners. And those are pharmaceutical partners on the one side. So we have those on our call today. Then we also have on the other side our registry, our International PC Research Registry. And of course, that consists of all of you patients and your data. And those two things, as they intersect, is the reason why we're going to get a cure and why we're getting effective treatments coming along today. I wanted to share with you this, a little story. And it starts with banana cake. And I apologize to the researchers who have heard me say this before. You're probably going to wonder, what in the world does PC Project have to do with banana cake? But in the early days of PC Project, in the early days of COVID, when everybody went home, I don't know if you kind of remember that. It was a little eerie. My college kids came home and we weren't really going outside. We were all kind of locked down a little bit. And I wanted to do something special for my family. And so I followed this brand new recipe for banana cake, and I followed the ingredients exactly. But when I put it in the oven to bake it, about halfway through, I looked at the cake baking, and it was falling over into the oven, the batter, and it was a mess, and it went sideways, and I pulled it out and I tried to fix it, and it was a mess. But I put it back in the oven, and I didn't know at this point now how long it was going to take to cook it. And I have to confess, I even cried a little bit, because here I was trying to do something so good for my family, and it turned out to be a disaster. Well, I took it out of the oven, and you can see out of the corner, I tried a little bite of it. And I have to tell you, that cake was delicious. I know it looks ugly, but it was delicious. And then we put on the cream cheese frosting, and it was even better. And it was wonderful. And you think, why in the world, what does this cake have to do with our PC journey? Well, I wanted to tell you, the journey to meaningful treatments and a cure for PC may not be what we expect. It may take longer than we want. It may make us feel frustrated, sad, and disappointed. Sometimes we're feeling hopeless. Sometimes it goes sideways. And sometimes this journey is messy despite our good intentions. But if we work hard, we don't give up, we remember our whys, and I put love in parentheses because that is our why. We love this patient community. And because of that, our journey will be successful because we have the right ingredients. And our right ingredients are right here, this powerful International PC Consortium, and of course, you patients here in our registry. That is how we're going to get the cure. And I want to just show you how this group intersects. First of all, we would not have a consortium, we would not even have a registry if we didn't have our IPCC. And again, if you see the IPCC, that is just our consortium. Just think professionals, researchers, medical doctors, those people. And they are the ones that said clear in the beginning, when we met together with our scientists, you need to have a registry, and they've helped us with that. So as the International PC Consortium has grown, I just wanted you to know, if you're new to us, we have every year an annual IPC symposium. And this is a picture from our last one in Portland, and it was a hybrid meeting. We had over 90 professionals on our meeting who were interested globally about PC. We also have a medical and scientific advisory board out of these members. And then even more specific, we have a steering committee that gets on with us once a month and guides us. I wanted you patients to know, if you don't know already, that we have IPCC members all over the world who care and who are working for PC patients. And this is a picture of some of our conferences, some of our patient support meetings. We've got them. So happy that we have these. I want you to just know that there's people out there that are working with us, that are that care about us and doing things in our disease space. Back to the registry, patients need a diagnosis. You may be one of them. A lot of times patients find us through an internet search of their symptoms, not because they know they have PC. Most of them come to us without a diagnosis. And as you know, the registry has diagnostic questions and we offer free genetic testing. It's very expensive to do genetic testing and we offer that for free. And I hope some of you have felt, as we do, that getting a correct diagnosis is life-changing. So that's the registry side, but then our IPCC members help with the diagnosis and more. Now, as more doctors know about PC, they're starting to refer their patients to us, or they encourage their colleagues to refer patients to us. They assist us with care questions. I'm not a doctor, and so we can ask our IPC questions. If you have questions of us, then we ask them. They help us learn as well, so we can help patients. I always have to show this slide because we have this team that gets on once a month with us. If you are part of our registry, your case has been reviewed by this team. And that's why we have, oh boy, I have a typo right there in our IPCC registry. These are literally the world's experts in PC. Sorry about the typo. Anyway, love these people and are so grateful for them. So we learn so much about PC from the registry. We have patients in over 60 countries. We love them all, and that means you on this call today. And the registry, this is why it's so important. When we first started PC Project, there was so much misinformation about PC, but that's not the case anymore. The registry teaches what is PC and what it is not. And Pachyonychia literally means thick nails, but I know there's patients in this registry that have some pretty thin nails and they don't get a diagnosis. So here we go. And I have to always put this slide up at the beginning of every patient support meeting. The registry has taught us that PCers are similar, but we are also very different. We are different in our mutations, in our pain severity, but we're the same, but we've got differences. You can see it affects us differently every time. Some patients blister, some don't. It's okay. I'm just going to skip this. Oh, maybe I'm just going to say the primary feature is painful plantar keratoderma. That is the sores on the bottoms of the feet. That is the main commonality that we have. So again, Pachyonychia, the word literally means thick nails, but the registry gives proof that the biggest problem of PC, of course, is pain. And I know many of you have told me that you're still trying to get that word out to your doctors to convince them that those calluses mean pain. I think you can see how many of you sleep with your feet out of the covers, how many of you crawl, how many of you have to trim your feet, how many of you have to use walking aids, even if it's a bicycle, to get around. So pain is the #1 issue. So that's the registry. It's taught us so much. But then the IPCC members, they come and they use the de-identified registry data. I have to say de-identified because we don't share your name, your birthday, your city, nothing with our registry, with our researchers. So just know it's very protected, but they take this registry information, they study it, they learn from it. The data gets published in medical and scientific journals. Then these scientists work in their own labs to collaborate with others. They speak at about PC at medical and scientific conferences, not just our conferences that PC Project hosts, but they go out in the world and they talk about PC to other people. And we love them for that, for sharing about PC with others. And of course, they train medical students, which is great. I just had to throw up this picture. This is Dr. Casper and Dr. O'Toole at our last meeting. You might have known from that we went to Amsterdam. We went for a very key scientific meeting, but we also went to a big scientific meeting. And this is us getting the word out. You can see the cute little feet on the table. As doctors came, we said PC is all about sore feet and sometimes painful cysts too, of course. And but just don't squeeze them. And you can see it says just calluses, think again. And so we love that we're getting the word out, not just through PC Project, but through our IPCC members. And of course, what we all want at the end of the day is a cure. And you can't have even effective treatments get passed. And we'll talk about this later on in our program, is we're going to talk about clinical trials. You cannot have a clinical trial without patients. And so our IPCRR is full of patients. We know who they are. We know where they are. Look at, you guys are right here and we know you because you're in our registry, and you have to be genetically confirmed and willing to participate in a trial. And we love you for doing that. Patients also share their voices. They give input on endpoints. They tell us what's important. They tell researchers what is important. We care more about pain. We care more about cysts. We care more about the sore feet sometimes than even the thick nails. And then on the other hand, we have our IPCC professionals. A lot of our studies are based on their research. A lot of the studies, the IPCC members are often the investigators of the studies. So if there's a clinical trial, it might not be some random person. It's going to be one of our IPCC members, a doctor that knows. They also give input and advice about the studies. And of course, they advance their research to get to the next level. And I think you'll see this later on in our program today. I just have to tell you, our registry never stops growing. Sometimes I think, have we maxed out on PC patients? No, we continue to get new patients all the time. Every week we get new patients. And this is the trick, guys. The registry is what makes us attractive to pharmaceutical companies. We often say, who would ever care about a rare disease like ours? It's our registry that convinces pharmaceutical companies and researchers that there are patients out there and that they will be in trials and that they will share their data, and that but the most important thing, they want to know, if they develop a drug, will there be patients who can get that drug? I mean, I hate to say it, but that's kind of the truth. So thank you so much for joining the registry. But because of this, because of the way the IPCC works with our registry, that is why physicians, scientists, and drug developers are always going to be welcome at our PC patient support meetings. And for any of you scientists, physicians, and drug developers that are on today, welcome. We're so glad you're here. We want our professional people to learn about us. And this is from Boston and London, just right before the patient support meetings before COVID hit and we went all virtual. But you know, every time we gather, we're starting to gather again. And in 2022, we had 3 little mini patient gatherings. And I just want you to know all of those were associated with a bigger scientific conference, because honestly, we're a nonprofit, we're cheap. And so, but good news, this year in New Orleans, you guys, just wanted to let you know right here on this call that our registration is now up. We're going to have our first in-person patient support meeting since COVID started. We're very excited about that. Why New Orleans? It's because our researchers and doctors got a session for the American Academy of Dermatology, which is in New Orleans this year. We've never had a session before. We applied for it. We got it. Ellie Sprecher, our chair, applied for this, sent in a proposal, and we're going to get to speak to a bunch of dermatologists in New Orleans. So we're going to have the in-person patient support meeting. So if you are, especially in the United States, consider coming. The information is on the website. We'll have an email out to you this probably Monday or Tuesday. Last thing about the registry is that it hurts emotionally. That's one thing that we have learned about PC. One thing is we've noticed that depression is the #1 emotional and social concern with our PCers. We've learned that from the registry. We've learned that patients deal with bullying, shame, embarrassment, and isolation. And this is not to make you feel depressed. We're here to be uplifted and happy, but we know it's hard sometimes. But our IPCC members give us hope. We love that there's people out in the world who care about us. So if you haven't joined the registry, you can do it, but thank you if you have. Wes wanted to say again, thank you to all of the people that send in pictures of what it's like to live with PC. We share these now all the time. I do not ever go to a scientific conference anymore without talking to the researchers about the difficulties of PC, whether you have a mobility aid or not. Just wanted to thank you, but also look at all the people in these pictures. There are people helping, carrying, lifting, And that's what our community does. We help each other, we lift one another, and that's what we're all about. And so just again, I want to give you guys hope. It just seems like it takes so long, but just remember in 2020, when we started PC Project in 2003, we're going to celebrate 20 years next year. We had nothing going on in our disease space, but here we are now today, and we have the right ingredients. We have our professionals and we have our patients. We work as a team, and we're going to get things done. Together, we are stronger. And just can't thank you enough for being here today. And I hope that the entire program of today will help you all know that together we are stronger. We're all individually, okay, I was by myself, a spontaneous mutation, but now we have all of us, we're together. And so with that, I'm going to close my remarks and continue on with this great meeting. I would like to turn the time now to Dr. Robin Hickerson, who's going to give our next part about PC and PC basics. So Robin, go ahead and share your screen. You're on.
You need to unmute.
Okay. Can you see my screen now?
Yes.
Okay, fantastic. Thanks, Jan, for that wonderful introduction to the meeting. It's very exciting. The idea of an in-person meeting is amazing. I'm very much looking forward to that. So Jan asked me if I would just give 15 minutes on PC basics and including how PC is inherited. So I'm going to hopefully get through these slides in 15 minutes. If you have any questions, I guess you could raise your hand, like the little hand on Zoom, and maybe Holly will get the questions to me in the chat. I think that's probably the best thing to do. So Pachyonychia congenita, so PC. PC is an ultra rare condition. It's a genetic disease, meaning there are changes in for Pachyonychia congenita in the keratin genes. And these genes are the keratin 6, A, B, and C, and keratin 16 and 17. So mutations, and sometimes it's only a single nucleotide or a single letter of the 3 billion bases in the DNA is changed in one of these 5 genes. And so every cell in your body has the exact same copy. Well, other than your sex cells, have the exact same copy of DNA. And like I mentioned, if you have a change in one of the keratin genes in your DNA, this results in it can result in Pachyonychia congenita. And the way that could look in your actual skin cells is what we can see here. So keratins are involved in providing strength to the cells. And so you can see on the left side, you can see a network of keratins, and those keratins provide support and strength for the skin cells. And so if you had some of the mutations that you could have in keratins could result in essentially just a collapse of those keratin filaments. So instead of having the filaments that provide strength, there's just the network has collapsed, and you just have disordered keratin filaments, or essentially not really even filaments at all. And Roger Casper has always had a good, I don't know if Roger came up with it, but Roger has always mentioned that this is a good kind of analogy of what we're thinking of when we talk about keratins and their role in the cell. If you build a house, at least in America, you use a wood frame. And you can see here that this wood frame is going to provide the strength for this house. But in a PC patient, instead of having in all of your skin cells, instead of having this nice wood frame giving support to your skin cells, you just have this collapsed wood frame. So here's just wood chips and sawdust. And so the skin cells of PC patients don't have that strong and functional support. And that's what leads to the clinical findings. So that's what leads to the symptoms in PC patients. So I'm going to talk a few slides about the symptoms of PC. So thick nails. So obviously, a lot of you will have thick nails, maybe only on one toe or one finger, or maybe in all of your fingers and all of your toes. And that's where the name PC comes from, because thick, pachy means thick and anychia means nails. So thick nails is where Pachyonychia congenita comes from. The congenita just means that this is a disease from birth. So it's a genetic disease. And blisters and calluses are also a clinical symptom, a symptom of PC. And the pain associated with these, as Jan mentioned, is not always obvious to lay and also to dermatologists. So it's not 100% obvious that there's significant pain associated with the calluses, but of course, all the PCers know that's absolutely a symptom, is the painful calluses. And here we can see calluses from a number of different patients with different genetic mutations. So these first four panels, these patients have keratin 6A mutation, and then these three patients have keratin 6B, and these two patients have keratin 6C mutations. And then we have keratin 16 and keratin 17 mutations. And all of these, all of the blisters and calluses on the feet, I mean, they do have similarities and they have differences. And it's not really clear from looking at the pictures what sort of mutation the person has. That's why, as Jan mentioned, it's so important for to do the genetic testing and know what the mutation is in order to help better understand the disease. Cysts are also a problem with PC patients. They are sometimes keratin 17 patients might have a higher chance of having cysts, but it seems that all mutations can result in cysts and painful cysts on different parts of the body. And follicular hyperkeratosis, which we see here, is typically a problem for teenagers and children, and may resolve as the patients get older. And then there's also leukokeratosis, which is essentially keratin buildup on the tongue that is also a symptom of PC. And then neurovascular structures. So these are essentially they're blood vessels and nerves that, instead of being protected deep in the skin, are more on the surface of the skin. And it's my understanding of these is not very much, essentially. I don't know why this is happening. Maybe some others on the other PC physicians and scientists know more than I do about these. But what I do know is that it makes it very difficult to trim calluses when you have these, because obviously they bleed. Jan showed a picture of somebody had trimmed their calluses and there was there was blood involved, but also the fact that these are innervated, there's a nerve associated with the blood vessel, and I can't imagine how painful that must be when the razor nicks that nerve. And so this is and this is also a very painful symptom of PC. So there are other challenges and features of PC, sharp ear pain, especially in children, difficulty sucking as infants, white keratin film on the larynx. Patients could have sores in the corner of their mouth. PC babies can be born with teeth, and there's oftentimes a deep itching under the calluses. And so these are all symptoms that PC patients may or may not have. And the only way to really understand the prevalence of each of these symptoms is to have as many PC patients genetically tested to determine their mutation, and then fill out all the forms in the registry so that we can have more and more data to understand the symptoms and how those are related to specific mutations, but also just in general understanding Pachyonychia congenita. So let's get into the numbers of these symptoms. So the plantar keratoderma, so that's calluses on the soles of the feet, is the most common feature in all 5 PC types. So with all 5 of the genes that are mutated to that result in PC, this calluses on the sole of the feet is the most common symptom. So 90% of PC patients report this calluses on the feet. And of the 101 reporting no keratoderma, 98% were younger than 10 years of age. So essentially, if a patient does not have plantar keratoderma or calluses on the sole of their feet by the age of 12, they most likely do not have Pachyonychia congenita. And plantar pain, as I mentioned, not only do you have the calluses, but it's very painful. And 94% reported plantar pain. And it's interesting to know that of the 57 patients that did not report plantar pain, the majority of those patients were under the age of 12. So only 1% of people with PC above the age of 12 report no plantar pain. So pain in the feet is definitely, or in the sole of the feet is definitely one of the hallmarks of PC. And so although each patient does not have all the PC characteristics, so you might not have the hyperkeratosis on the tongue, or you might not have cysts, but of all the patients with genetically confirmed mutations, but none of the patients with genetically confirmed mutations only have thick nails. So even though the disease is called thick nails, so Pachyonychia congenita means thick nails from birth, none of the patients only have thick nails. So if a person, essentially an adult or someone over the age of 15, only has thick nails with no other symptoms associated with PC, they most likely do not have PC. And so here we can see some more feet, similar to what we've seen before, with thickened calluses on the bottom of the feet. But the reason that genetic testing is so critical is because none of these patients that you see here actually have a mutation in one of the PC genes. Some of them have mutations in other keratins, and some have mutations in non-keratin diseases, genes, sorry. So it's really critical that that genetic testing is performed in order to make sure that we're not confusing other diseases with PC, because it's really important to have all the information so you can have a full understanding of the disease. So the last part of my talk is about how PC is inherited. PC is a genetic disorder, and if one of the parents has PC, there's a 50% chance that each pregnancy will result in a child with PC. If neither parent has PC, then there is a very, very, very low chance that a pregnancy will result in a child with PC. And I'm going to just show some images to depict this. This is an egg about to be fertilized by a sperm, and so in this case, this would be all of these sperm are similar genetically, not exactly the same, but similar. And then you can see that if the dad has PC, then half of his sperm will carry the PC mutation. So for each pregnancy, it just is a matter of chance to which of these sperm will fertilize the egg. Is it one of the sperm without the mutation, or is it one of the sperm with the mutation? And that will determine whether the child has PC. And it's the same with the mom. With all of the eggs that the mom has, if there's no PC, then obviously there's very little chance that any of the eggs will have a PC mutation in them. However, if the mom has PC, then half of her eggs will carry the PC mutation. So it just depends on which of those eggs is fertilized will determine whether or not the child has PC. And like I mentioned, 50%, if a parent has PC, there's a 50-50 chance that each pregnancy will result in a PC child with PC. So there are spontaneous cases. Jan mentioned that she's a spontaneous case. It's I don't know if it matters whether the sperm or the egg had the PC mutation, but in the case of spontaneous patients, there's a very small percentage of the sperm. So a typical dose of sperm has hundreds of millions of sperm, And if one of those has a PC mutation and that one happens to be the sperm that fertilizes the egg, then the child resulting from that will have PC. And it's the same thing with the mom, with the hundreds of thousands of eggs that an individual mom might have. If one of those has the PC mutation and that's the egg that happens to get fertilized, then the child then will have PC. But it's a very low chance. The spontaneous mutation is very, very rare. So what can we do about this? So there is a technique called prenatal genetic diagnosis, or PGD, and it's a technique that allows couples to essentially use in vitro fertilization to check whether embryos have a PC mutation. And obviously you can discuss this with your genetic counselor or clinical geneticist. I was just going to show a couple of slides to describe what happens in PGD. So in vitro fertilization, it's when an egg is fertilized with the sperm outside of the body. So this is essentially done in a test tube. And what happens when this egg is fertilized is that it begins to divide, and approximately at the 8-cell stage, typically in vitro fertilization, there's maybe 6 to 8 of these eggs are fertilized, and so you end up with a certain number. So say you end up with 5 fertilized eggs. Then when they get to the 8-cell stage, so they've divided now 4 times, and so they're at the 8-cell stage, then you can take one of those cells from the embryo and you can actually do genetic testing on that cell. And from that information, you can determine which of these embryos was fertilized with essentially a wild, that has wild type sperm and egg, or if one of the eggs or one of the sperms had PC, you can tell at this point. And then you would only transplant or implant the embryos that don't have the PC mutation into the womb of the mother. And so this is how this works in a nutshell. But if you want more information about this, you can obviously talk to your doctor. And I really appreciate you having the opportunity to participate in this meeting. And if there are any questions, I don't know if we have time, Jan, we could ask some questions now, or potentially we can ask them at during the panel discussion.
If you have a question, put them in the chat. Would that be okay? I think we'll keep moving if that's okay, Robin.
Perfect.
And just so you know, Robin is a great scientist. And Randy, if you want to be sharing your screen, that would be great. Robin has to go to the airport right now. And so she's going to another scientific conference. So we're excited that she was able to be part of our group today. Robin, we know when you have to go, and that's okay. Just thank you so much for sharing your time with us today. And then
it's great to be here. I'll be listening in as I drive to the airport.
I love it. This is great. Oh, Sylvie's got a question. It looks like I just saw it come. Sylvie, about translation. Oh, maybe they didn't get to see it. It might be because there were words that weren't all in there, Sylvie. Well, Holly will answer you in the chat. How's that? I'm going to just keep us going here. Our next speaker is another doctor, and he's right here. He is right here from Utah Valley. And I know his family very well. He is a clinical psychologist. Maybe I'm just giving your introduction here, Randy, but he deals specifically in pain. And so many of you, when you registered, said you wanted to know about pain. And as I got to talking to him, I was actually at a dinner with him one evening, and I thought, wow, he has so many good ideas about pain. I thought this might be really interesting for us as a group. So I'd like to turn the time now to Dr. I'm going to say it wrong, Gilliland. Did I do
you
okay,
said it right.
Randy? Perfect. I know his wife really well, so it's just Randy and Jessica. But thanks for being here today, and I'll just give it to you.
Thank you. Yeah, I'm Randy Gilliland. We're getting over COVID, so my voice is deeper than normal, and so hopefully you guys can understand me this morning. But I'm a clinical psychologist. I work at Utah Valley Pain Management, and I'm happy to be here with you today. I'm new to PC, so Robin's presentation was very helpful. It helps me to know what you struggle with and the challenges, the unique challenges that each of you struggle with. It's difficult to be a pain expert in that pain is so individual, and I consider each of you to be the real experts of pain. And my job is to help you become even more of an expert of your pain and better understand it. So I just want to go over quickly the key points, what I want each of you to take from this presentation. And to start off, I just want to validate the fact that your pain is real. That pain is distressing, it's challenging, it interferes with life, it interferes with every aspect of life, and that's okay. It's okay that it's difficult because it's real, and that's part of the purpose of pain, is to warn us, is to let us know that something's going on. And the problem is when it becomes chronic, it really starts to interfere with, like I said, every aspect of life. And it's okay that it does that. It's playing its part, it's serving its function. And my job is to help you explore ways to manage that in a way to help you live the kind of life that you want to live. Secondly, pain is personal, like I said. Pain involves a complex interaction between biological, psychological, and social factors. And the underlying principle or underlying theme between these factors is threat. So anything that is actually or potentially threatening to the tissues of your body can possibly produce pain. And my goal today is to help expand your view of what you can do to help manage your pain, beyond addressing the tissues of your body, beyond addressing the actual sensations of pain. I hope to expand your view to, hey, there are some other things here that are going on that might be contributing to my pain that I can work on, I can address if needed. I can find a professional and work with them on these things. But I hope to help you see that there's more going on here, and there are more what I like to call intervention points, places where we can intervene. And my intention is to give you some hope that there are more ways here that we can help manage your pain. So how do we define pain? Pain, defined by the International Association for the Study of Pain, and this is the definition that the majority of us follow, is that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. A couple parts of this definition that I want to point your attention to is that pain involves both a sensory experience and an emotional experience. So in our professional definition or scientific definition of pain, it involves both. And so attending to both is important in your management of pain, both the sensory and the emotional aspects of pain. In addition, pain can be triggered by experiences that are either associated with actual or potential tissue damage or resembling that. So we don't actually have to be in the presence of something that might damage our tissues in order for pain to show up. A couple examples of this: I work with people with severe back pain, and even having them imagine certain movements that have been painful can raise up pain. Or if I'm working with someone who's had a traumatic experience, whether that traumatic experience is associated with pain or not, but just the increase in their body's physiology as we approach traumatic experiences can increase pain. Perhaps someone with PC, maybe the thought of putting your feet on the ground or the thought of walking is one of those experiences where you're not actually in the presence of something damaging, like you're not actually doing the act, but it's resembling potential or actual tissue damage, and so that could increase the sensitivity of your body and increase the chance, or pain might start at that point. And for me as a psychologist, that's one of the intervention points that I would start to work on with someone, is identifying those points where there isn't actual tissue damage happening in the moment, and working to desensitize the person to those moments. A metaphor that a lot of us use in chronic pain is that chronic pain is like an overly sensitive smoke alarm. So an overly sensitive smoke alarm, or the purpose of a smoke alarm is to go off when there's smoke. An overly sensitive smoke alarm, actually a couple of months ago, we had that issue here in our house, and an overly sensitive smoke alarm is annoying. It's not serving its purpose. And our job is to notice what are some of these factors that are making this smoke alarm overly sensitive and no longer serving its purpose, and work to turn down the dial of that sensitivity to help this alarm become more sensitive. My invitation to you today, and the invitation I'm gonna leave with you, is to have you explore your own factors that might be making your smoke alarm overly sensitive. A more practical definition of pain is that pain is a marker of the body's perceived need to protect its tissues. So when pain is there, that's an indication that your brain and body are perceiving that the tissues of your body need to be protected, and so pain is produced to guard or protect those parts of the body. Pain helps us escape, avoid, limit, or stop actual or potential tissue damage, while teaching us to avoid situations or behaviors that might be harmful. And so there's a learning process with pain. We're learning, as our body produces pain, we're learning what could be damaging to the body. The problem with this learning is that we might be learning to avoid things that are actually helpful. And so part of my job, or my exploration with people, is what's pushing yourself too far and causing damage, and maybe what's not pushing yourself far enough in doing, what can you do within your range of functioning to where you're not either causing harm to your body, or you're not flaring up your pain to the point where you're making that smoke alarm even more sensitive. And so part of our job is to find that happy medium to where you're being as active as you can be, you're doing the things that you can do, you're not overdoing it, you're not underdoing it. And so we're trying to find that just right place, and that shifts. Pain, daily pain can be in a different place, and so that happy medium might be in a different place every day, depending on the weather, depending on stresses, depending on how active you were the day before. And so, but that exploration is important. It's important to kind of explore, okay, today, how much is too much? How much is too little? So I just want to go over our historical view of pain, or how we previously viewed pain, and how we viewed it in an incorrect manner. So this graph represents an old view of pain, in that if there's no pain going on in my body, then there must be no damage occurring. Or if I'm having some pain, there must be some damage, but if I'm having high or extreme pain, there must be great damage occurring in my body. And this isn't an accurate view of pain, but unfortunately, some medical providers continue to view pain in this way, that if there's no pain, there's no damage. If there's some pain, some damage. Hey, if there's great pain, that there's this clear association between pain and tissue damage in the body, when in reality, pain is not an accurate measure of tissue damage in the body. Pain is a measure or a representation of protection, and that my body is perceiving that my tissues need to be protected, regardless of whether or not there's actual damage occurring. So our current scientific view of pain looks like this, in that we take in information in the tissues in our body, our nerves, our senses. We take in information from the environment, and then the higher centers of our brain then combine that information with other information, our past experiences, our history, what we know, what we believe, our culture, the setting that we're in. And then from there, our brain makes a decision. Is there credible evidence that the tissues in the body need to be protected? And if so, then our body will produce pain in order to protect that part of the body. And so it's this complex interaction. There are examples. Just one example I want to go over. This was published in the British Medical Journal in 1995. There was a construction worker. There was a construction worker who jumped down from some scaffolding and felt something in his foot, and looked down, and he saw this. He saw a nail had gone through his foot. Immediately experienced intense pain, was taken to the ER. They administered opioid medication. They tried to get the nail out and take the boot off, but his pain was so extreme that they had to titrate up the dose of the opioids until the pain resolved enough for them to be able to pull the nail out, take his boot off. And as they looked at his foot, there was no damage. And the nail had actually gone just right next to his toes. But if we look at kind of look at pain in this way, of what's happening here. So he's feeling it. He looks down. He sees a nail through his foot. He's probably feeling it in the tissues of his foot. I would imagine being in a construction environment, he's around other people. I would imagine they're reacting to it as well. Who knows about his history with this kind of injury? But his body is taking all of that information in and deciding, okay, this foot needs to be protected, and because it needs to be protected, pain was produced. And so to immobilize him so he doesn't do further damage, and then they take him to the ER, and lo and behold, there was no damage. But one question I want to pose, was his pain real? And I would say yes, his pain was real. It was intense enough to put him down. They needed opioid medication in order to reduce or resolve it. So it doesn't mean that his pain wasn't real because there was no tissue damage. It indicates that his pain was real, but also all of these factors combined to tell him that there was damage occurring and that he needed to be immobilized in order to protect his foot. And so with this situation, there were all of these signals of threat going on. The visual image of the nail through the boot. And again, who knows what was happening around him? Perhaps his coworkers were expressing concern or telling him to get down. And so there's all of these signals of threat that he's receiving. And so I invite you I want to kind of turn or encourage you to be introspective and think about, the areas in your life where there are signals of threat. And I'll indicate a few areas to consider, but if there are more, I want you to kind of just explore, where might threat be going on inside and around me. So starting with things inside your body. Obviously, the signals of pain are threatening, but stress signals, is my heart increasing? Am I feeling tension in my body? And part of my invitation, or part of the reason why I'm inviting you to do this as well, is just to see, okay, are there other things going on that might be amplifying my pain, in a way to kind of put the pain in context. So, if we're stressed out, that can amplify pain. If there are hormonal changes, if there are weather changes, if we're adjusting medications, these are all things that can either increase or decrease pain. And so just one area to consider. Another are things that are going around in your body, the environment and the setting that you're in, especially when pain is elevated. And then also considering, hey, when my pain is better managed, like, where am I at? What am I doing? Things that you're doing, are there particular movements, particular activities where you find the pain occurring more? And are there movements and activities where you find the pain occurring less? So I talked about the principle of threat underlying pain. The alternative to that is safety. And so a big part of my work with patients is to help increase their sense of safety. So we explore these different areas where threat might be occurring, and then to pinpoint, okay, this is where it's happening. What can we do to bring in a sense of safety in each of these areas? And so considering kind of movements or activities that you engage in, both ones that bring threat and ones that bring safety. And then with the ones that bring threat, okay, like, what can we do to help increase a sense of safety related to this particular movement? Places or settings that you're in, are there environments that increase or decrease your discomfort? People that you're around, are there particular people that you find increasing or decreasing your sense of threat or your sense of safety? Some people that I work with, as they go through this, often this is kind of the first homework assignment, is to start exploring these factors. And some will say, oh, when I'm with my spouse and we're talking, I do notice that my pain, it's not that I'm not noticing my pain. My body feels safer and I'm not in as much pain. But when I'm with this other person, maybe when I'm around my boss or somebody else, I do notice that I'm on guard more and my pain is a bit more amplified. And so relationships are an important thing to consider. Your thoughts, your feelings, your beliefs, your expectations are all things that both can amplify and then also reduce pain. And so exploring, what am I thinking about related to my pain or about myself? Emotionally, what am I feeling? What emotions are coming up? What am I expecting? And these are all areas to consider that might increase or decrease that sense of threat. One thing I wanted to kind of clarify, that this line that says, in general, positive thoughts and emotion decrease pain, while negative ones increase discomfort as well. And I think one thing within mental health, I think sometimes we can put a bad stigma on negative emotions, on sadness, on hurt, on anxiety. And in fact, like, these are all purposeful and functional emotions. And so I think one way to make kind of these more negative or distressing emotions to have a kind of a positive interaction with them is just to acknowledge that they're there and that it's okay. And so I just want to add that caveat, because all of these are part of the human experience and all of them have purpose and function. And so it's okay to feel sad. It's okay to feel hurt. It's okay to feel anxious. And it's the way that we relate to them. We can relate to these emotions in a healthy way or in an unhealthy way. And I can talk further about that if needed. In addition, our senses are things we see, hear, smell, taste, or touch can amplify or decrease pain. I wish I had this specific citation, but I heard a presentation where a pain researcher was doing some studies where they applied a painful stimulus to a person and then they sprayed fart spray, and found that in the presence of fart spray, I don't know if that's unprofessional for me to say, the pain was actually amplified. And so our sensory experiences, experiencing a distressing sensory experience can amplify pain as well. So these are all, again, my goal here is to broaden your view of what can you explore, or what factors might be contributing to your pain, that give you different intervention points in order to manage your pain. I'd like to go over just some general psychological interventions that I do with my patients, some things that you might consider and look into. First off is learning about pain. The technical term, we call it pain neuroscience education. I've provided some resources, a website and a few other resources to start this process. And so learning about the pain system in the body, learning about how the body produces pain can be empowering, and again, give you some intervention points or other ways that you can work on managing.
Oui, ben c'est émouvant, mais je trouve un peu long pour les autres intervenants. Merci.
Is that a question?
I think you're okay. I think it was just a quick unmute.
Okay.
Carry on.
Cognitive behavioral therapy for chronic pain is an intervention that helps kind of educate you about and help you explore ways that thoughts, feelings, and behaviors increase and amplify pain, and then work through ways that these different areas interact. And then also within CBT for chronic pain, there's different modules focusing on sleep, focusing on exploring and including enjoyable activities. And so that CBT for chronic pain can help people work through ways that their thoughts, emotions, and behaviors increase their pain. Mindfulness is both a meditative practice, but also a way of living, of being open to experience. There are lots of formal and informal mindfulness courses available, but it's a great way to work with pain. One specific intervention that I often do with people is what we call clean pain, dirty pain, but it's where helping you differentiate between the sensations of your pain. Okay, so first off, where's it at? Is pain, is it a burning pain? Is it aching pain? Is it a throbbing pain? And then the other things that come related to pain, emotions, memories, experiences, urges that are there, and helping tease those apart, and then working with both. So as a therapist, sometimes I would help someone maybe be mindful of their pain, and then maybe we work through those other things that come up, the thoughts, the emotions, the memories, the urges. Self-compassion is an intervention I often use with patients. With self-compassion, compassion has two parts. So first off is a willingness to see suffering in myself and in others. And so if I'm to be compassionate, I have to turn towards the hard things. And then secondly is a willingness to do something about it, a willingness to act on helping or offering support. One self-compassionate intervention I often use is helping people hold their pain in their body in the same way that they would hold a crying child. Holding a crying child is distressing. I mean, the child's distressed, and working to see pain in that same way. Lastly, one thing I often find myself working with people on is acknowledging and grieving losses related to pain, things that whether it's a loss of humanity. In the previous presentation, like bullying was mentioned, having difficult or rejecting or dismissive interactions with healthcare professionals or others, missing out on opportunities to do things, having to cancel things in order because the pain's elevated that day. And so these are all losses, and it's healthy to acknowledge and grieve those losses in order to be able to move forward and acknowledge how these things affect you. And so that's often something that I end up working with people on. Lots of books out there about grief, and so if you feel like that would be applicable to you, and feel free to email me if you have questions or anything I can be available or I can be helpful with. But in my slides, I have lots of resources for mindfulness and ways of learning about pain. And so Jen, you're welcome to send these out, or the handout that I sent you with these same resources. I think I think I'm at time. If not, I can take some questions. If not, we can end here. Jen, I'll let you.
Sounds great. Randy, thank you so much. I think it's really validating to know, I mean, everybody on this call probably has some kind of pain one way or another, whether it's foot pain or maybe if you don't have PC, everybody experiences pain. And those were such great, important truths. I think for the sake of time, we might move on, but if you have a question, put it in the chat or save it for our discussion groups on at the end of this, our last hour. We're going to talk about pain as ourselves, or excuse me, I can't even talk. In our discussion groups, we're going to be talking about how PC affects us. And I think pain is huge. I loved, Randy, your last thought about pain and about how we need to be compassionate about ourselves. I've never thought about the fact that we have to grieve it. I know even in my own life that I've grieved the fact that I can't do certain things. I've wanted to play tennis. I've wanted to go on hikes. I live, and I think that's a real aspect of grieving. So thank you so much for all of those good points. I will get that handout out to everybody because there's some great resources about pain. So thank you so much. Appreciate you.
You're welcome. Happy to help.
That was fantastic, and especially coming off sick. that was even nicer. So thank you. There's a lot of junk going on right now. So grateful for you, Randy. Thank you. I guess I should ask, if you have some questions, put them in the chat. There has been a little bit of chat, but not so much in questions. So if you've got to put them in the chat, I am going to turn the time now to Jack. Jack is our board chair. And so we have, I talked earlier about our, we have an MSAB, meaning a scientific and medical advisory board. But on the other hand, we have PC Project Board of Trustees, and these are individuals. I think Jim is on the call, Jack is on the call, and these are people that keep us running. We have to stay compliant as a charity. We have laws, we have regulations that we have to follow, and Jack is the great chair of us. In fact, I wasn't excited about being the executive director, and Jack said, if you be the executive director, I'll be behind you all the way and I'll be your chair. So Jack, I'm handing it to you and just thank you for all your service.
You're welcome. Thanks, Jan. So here is I don't know, how do you do a virtual hug? Do I just like hug the screen? There's so many familiar faces that I haven't seen in a while. Al, Aaron, Helene, Dr. Hanson, Robin, Jim, Wes, Roseanne. And then for those of you that I haven't met or seen, it's very nice to meet you. As Jan said, I am a volunteer with PC Project and also a PCer. And I just want to talk a bit about what's coming up for PC Project. Not only is Thanksgiving around the corner, one of the best times of year that we give thanks, but so is Giving Tuesday on November 29. And why is this important? It's important because Giving Tuesday is our biggest fundraiser of the year. It's the one time a year where we raise the most money for PC Project to pour into realizing our mission of finding treatment and eventually a cure. And it's really a time for us to celebrate how strong we are as a community. It's also the one day when people really across the world, because this is an international phenomenon, when people are looking for causes to support and a great opportunity to expand our reach and find new supporters, to get people to care about so few of us that have this disease worldwide. You know, Randy's very interesting discussion about pain makes me even more excited to share with you our theme for this year, which is up on the screen, Stronger Together. Why? Because I think when it comes to easing our pain, there are really two ways we're stronger together. First, treatments and a cure can only happen by working together with the people on this call, patients, scientists, doctors, pharma. And secondly, you know, for me, and I know for a lot of you guys, carrying the pain that we feel is easier when we have a community that supports us. People like you and me. So, you know, we PCers know the challenge of living side by side with pain. For me, personally, it's a daily struggle. And it's best described by using, and I use this analogy when we testified in front of the FDA. So those of you that heard it already, sorry, but you'll hear it a second time, but I use a bank account analogy. And it's not the kind of bank account you're probably thinking. This one isn't filled with money, but instead it's filled with a number of steps that I can take physically every day before that nasty PC pain sets in. And, you know, just like a checking account filled with money, I spend it very wisely or try my best. Each withdrawal or step I take is mentally recorded, physically felt, you know, right down to my bones. And overnight when I sleep, fortunately, that bank account is refilled before I wake up. But the amount of that refill varies. You know, if I took too much out the day before by walking too much, I have much fewer steps on the account. If I get a good night's rest, monitor my walking, that account then goes back to full when I wake up. You know, for me personally, and I know everybody is different, on my best day, I could walk down a long city block without thinking once about my pain. On the worst day, I don't want to walk. I just don't, period. And as Randy said, you know, my PC hurts both physically and emotionally. You know, PC pain for me feels like someone sticking pins and needles in the bottoms of my feet. And then it's also a deep ache that just cuts all the way to the bone. You know, I treat it with hot water soaks, cold water soaks. I elevate my feet. I've tried every rubbing cream on the market. I've tried massage, Vaseline baths, Advil, and a lot of bitching. Sorry, should have, there's probably kids on the call, but mostly under my breath. But honestly, nothing really works. Nothing really takes it away. It's just constant. It makes me grouchy, sometimes to the point of lashing out to the people I love, which is the one thing you don't want to do, or the people I work with, or even total strangers. And I know that it contributes to my struggle with depression over the past 20 some odd years. As most of you know, it makes your fingernails ugly, so ugly that growing up, kids made fun of me. PC makes me walk weird. It's that something that Mary Schwartz said to me when I first met her and came to my first PC support meeting. She said, "You've got the PC walk." And she defined it perfectly. But kids, being kids, they didn't see any humor in it, and certainly didn't have any compassion. They just saw me differently, and as a result, was bullied, like most of us were. PC also impacted my parents. After I was lucky. I was one of the lucky ones. I'm 60 years old today, but I was diagnosed at 3 years old. My parents had a name for the condition because we found the right doctor, but that's all they had. They had a name, but no treatment, no answer why, especially no cure. My mom thought it was her fault for so many years. She thought if I smoked less, if I ate differently, if I didn't take aspirin, maybe he wouldn't have had this. Well, crap. None of that matters. I'm a spontaneous case like Jan, meaning it's not inherited. So when I came along, it was just like luck of the draw. My PC has changed my life, or better said, I've come to realize it is my life. And because it has enormous power, and because of that power, I respect it. I've learned to live side by side with it. But only after I stumbled upon PC Project and met other people just like you. For me, it's made me stronger in a lot of ways. And it's taught me to be courageous by being able to expose it to doctors and strangers and even people who love me, which is not an easy task. It's also taught me to stand up to bullies who have no interest in learning anything about PC except as a way to call me out as different. A lot of good life lessons. Through PC Project, the patients, the doctors, the scientists, the pharma folks I've met have all given me the strength to face even my worst days. And it makes me feel good to know that your support of PC Project helps give other parents the information and resources my parents didn't have. So yeah, we truly are, as a community, stronger together. And my story is just one example of how stronger together through PC Project. We've reached so many people, and it's only gotten stronger. And that's why I'm asking for some help today on Giving Tuesday. And really I'm asking for 3 things. And it's pretty easy 3 things, and it could even be fun. The first is mark your calendar for Giving Tuesday on November 29. That's number 1. 2, write a short message you can share by email or social media about how and why you support PC Project, and why finding a cure is so important. And I'm asking you to do something, but I'm going to also give you a sample of what that might look like. One of the things I wrote last week, one of my favorite nonprofits to support on Giving Tuesday is PC Project. They are fighting every day to help treat PC, a painful disease that not many people know about. Will you join me in making a gift to help them support PC patients like me and find a cure for PC in our lifetime? Thank you. So short, sweet, right to the point. And don't worry, we've created a link in that you're going to see in the email when you get it. That'll have access to several other sample messages that you can choose from, and make it your own, of course. And then thirdly, when Giving Tuesday hits, post a message on social media about why PC Project is so important to you, and ask your family and friends to learn more about it and to make a gift, to make a contribution. Those are the 3 steps. Now, I know some of you are probably thinking, well, Jack, I'm really not brave enough, strong enough, even good enough to post online about my PC. That's okay too. We are all on different paths in this journey. For you folks, simply post a message, general message, that you support PC Project and you like others to join in that support. Another sample message can be, this Giving Tuesday, one of the nonprofits I'm choosing to support is PC Project. An organization 100% focused on developing treatments and finding a cure for PC. So there are many ways you can contribute without having to get real personal about it. What we do know is the more personal and out you are about your PC, the more participation you get. But I understand, we're not all at the same point. Okay, I babbled enough. Opening your phones, scheduling a meeting, a reminder for 11/29. And the other thing is, we're going to communicate with you via email on all of this, so you don't have to remember anything I'm saying today, other than know that that we are truly, as a community, #stronger together. And so I think we have a couple minutes, Jan. If anybody would like to share, not in the chat, but turning on your camera and turning on your voice. Does anybody want to share, give us a quick example, maybe 30 seconds, about how being connected to PC Project has made you stronger?
I already see Jim's raising his hand.
I just want to point out that, first of all, I tend to not remember anything Jack says, so the email will be very helpful.
Thanks, Jim.
I just, PC Project, be like many of you, I was alone. I wasn't spontaneous. My dad had it, but we didn't know anything, and I didn't find out till much later. Without PC, I'd be alone in the dark. I mean, not knowing what I have, how to deal with it, other than, trial and error on my own, and which is how most of us learn, to just deal with it and to be able to continue in life. And when I found PC Project, I mean, I'll say, not putting it lightly, it wasn't just the lights coming on in the dark. I mean, it was earth shattering. I'm sure many of you remember that first conversation you've had with Jan or Holly or whatever, and the emotions just going crazy. So I really love the Stronger Together mantra. It makes us better. It gives us hope, just not knowing that we're alone. I think the first time I saw the Stronger thing was in Boston, when a community came together to heal. The rope picture there is great. I mean, a single thread is really weak, but ropes, put together, can hold massive cruise ships. A single ant can't do anything, but a colony can move mountains. And I've pictured before, all of us, like the human towers in Spain, I think they're called the castle, where everybody pushes and lifts that one person up to the tower, and that's us. I mean, we're lifting Jan and Holly in the medical research arena, to shout. I mean, there's so many examples, but to me, it's simple that I was alone in the dark in pain. I mean, it's that simple. And PC turned the lights on. PC Project turned the lights on, and so I have no doubt that with all of us lifting, I mean, that we're stronger together with PC Project. I mean, It's a great mantra.
Thanks, Jim. Anybody else? Somebody in the chat, I'm sorry, I don't have a name, but it just says R, said it's made me stronger in the sense that I'm not alone in this struggle. It gives me some kind of hope to keep going. Very, very well said.
Very well said. I think that's probably one of the biggest things, I think, is we're not alone at all, and I know I lived my whole life feeling alone, then I had kids and I wasn't alone. I made my own PC. I made my own PC friends, but meeting other people like you has really changed my life as well. Oh, Jade, and maybe Nathalie too, to feel understood and to be less alone, knowing there are only 8 people in Switzerland, so 6 of my family. Yeah, it's true. And that's the thing, is we're united clear across the world. This is great. You know what? Let's keep going if it's okay on our program, Jack. That was beautiful. Thank you so much. And I just have to, well, I guess, Helene, I have to read yours. We learn from the smartest scientists in the world, and we learn from each other, the youngest and the oldest, with and without degrees. That is true. And what PC Project is, it means hope. So keep looking at the chat, keep putting your comments. You never know, your comments might be in our next social media post or our next newsletter. And Jack, I really appreciate that I'm not alone, that I've got a great board, with Jack and with Jim and some of the others, Dr. Hansen, who's on our board of trustees. It's nice to have patients who are so committed and so willing. Really appreciate you all. And with that, we've talked about the fantastic scientists that we have on our team. I think you're probably more excited for this next one than anybody. Is Dr. O'Toole. Some of you may be you're under one of her patients. And Adele, you're welcome to share your screen if you'd like. She is going to give an overview of some of the research that we have going on.
Can you hear me okay? It says host disabled participant screen sharing. So maybe you need to enable that, Holly.
Yes. We'll give you the power. We can hear
Okay,
you.
I've got it now. Great.
Perfect. Take your time. Hi, Steve. Good to see Stephen. When we're not sharing the screen, I can see more faces. I love it. Patrick, Sabina, Selena, Jennifer. Hey, Jenny from the New York.
Can you see it now?
Not yet.
No, okay.
Hey, Allison. Hey,
Now?
there we go.
Great, thank you. So happy to talk to you all today. And if you have any questions, please put them in the chat. So I'm going to talk a little bit about clinical advances in PC and the power of the registry. I'm going to talk about treatment ideas in progress, and I'm going to talk a little bit about basic science. So Liat Samuilov and Ellie Sprecher from Tel Aviv looked at a case cohort study of 815 patients who have enrolled with PC Project. They confirmed that plantar pain was the main issue, but a remarkable 19% of cases used walking aids. So it is a real disability. 54.2% of patients reported cysts. 26.2% reported depression or mood change. And in most cases, changes to the nails was the first clue, generally in the first year of life. Chris Bunnick from Yale and Joyce Teng from Stanford published this paper in the Journal of Investigative Dermatology, which is one of the top dermatology journals in 2022. They basically looked at the structure of keratins. So up at the top, you can see there are various boxes. So there's 1A, 1B, 2B. And at the bottom in orange, you can see where most of the mutations are. So most of the mutations are in in 1A or 2B. So common mutations, for example, the N172del is a common mutation in keratin 6A. That's in domain 1A. And another one is R127C is a common keratin 16. That's also in 1A. So then they looked and they found that a high percentage of patients have pain on any walking. And they looked at this for each domain. And here you can see that with all PC mutations, 60 to 80% of patients had pain on any walking. But this was particularly marked in the 2B domain, which is in green. And then they looked at the percentage of PC patients that had pain that affected their mental health. And about 30% overall of PC patients have pain that affect their mental health. And you can see that this applies in all types of PC. So some people say PCK6C is milder, but that's not the case. You know, okay, there are less signs. Maybe the keratoderma can be less severe, but the patients are still suffering. Moore Pawlowski, again with Ellie Sprecher, looked at the association between PC and hidradenitis suppurativa. So hidradenitis suppurativa is an unpleasant disorder where you get boils in the groin area, in the armpits, under the breasts in women. And a survey of the PC registry revealed that 25.9% of PC patients that responded, so there may be some bias in the response, had hidradenitis-like clinical issues. And Moore and Ellie were able to show that keratin 17, if you make a little mutation in the gene, and then if you put it into cells, it decreases signaling of a molecule called Notch. And that seems to be important in hidradenitis suppurativa. So there is a reason for the association. Lloyd Steele, who worked with me, looked at PC and itch, again using the PC registry. We had 281 responses out of 756 patients surveyed. We were thinking it might be related to inflammation in the skin or related to changes in the nerves in the skin. And 68% of patients surveyed said they experienced itch, and 51% said they had experienced it in the last month. And the itch was particularly under the calluses and around the plantar calluses. The same applied in palmar calluses. And it was made worse by wearing shoes for a long time, walking, or heat. And it was described as tickling, burning, prickling, or tingling. Zhang Li, who was a medical student at the time, looked also at the registry. She looked at the neurovascular structures in PC, or the putative neurovascular structures. So we think basically that we know from ultrasound that under the calluses there are lots of blood vessels in PC, and patients describe when they pare down the callus, they get these bleeding points which are very, very painful. So it's postulated that there's a nerve and a blood vessel together causing this pain. And basically 62.3% of patients overall had these neurovascular structures. And it was a bit higher in PCK6B and PCK16, so over 70%. And in the others, it was 36 to 62 to 57%. So overall, 62% of patients had these. So in terms of treatment ideas in progress, there's rather a lot, but I'll go through them quickly because there will be some further talk about trials later. So Alan Hovnanian is going to talk after me about erlotinib. So he described treatment of Olmsted syndrome, which causes calluses on the feet, which are painful like PC. Olmsted is caused by mutations in a gene called TRPV3. And the epidermal growth factor receptor is a receptor on the cells, which is targeted by erlotinib. And it seems to be very closely related to this TRPV3. So they sort of regulate each other. And there will be future treatments, I think, targeting both of these. A group in Australia combined topical erlotinib with salicylic acid and showed an improvement in PCK16, which you can see here. And I met Christine Bodimer last week, and she told me that she has obtained EU approval for an erlotinib preparation as an orphan drug. A company in Israel, Kamari Pharma, have developed a topical TRPV3 inhibitor. And there is a proof of concept study currently recruiting in Israel for both Pachyonychia congenita and punctate PPK, which is a different type of keratoderma. But some of those patients also have a lot of pain. So the TRPV3 inhibitors target TRPV3, which is important in pain and itch. So just in summary, the sort of treatment pipeline, there's the trial ongoing, which is placebo-controlled of topical sirolimus. Topical and oral erlotinib have been reported mainly in small case series. An open label trial has started of a topical TRPV3 inhibitor. Roger Kasper continues to work on topical siRNA directly targeting PC mutations. This is probably the most elegant solution, but is also quite hard to get to work at a large scale. Other possibilities include topical or oral JAK inhibitors, which are now licensed for atopic eczema. So now on to the... So Diana Bladen has received a grant from PC Project, and she's going to use a technique called spatial transcriptomics to look at in detail at genes expressed in the skin in palmoplantar keratoderma, including PC and in normal palm. I'm doing some work on steatocystomas. I've got a grant from an organization called the Leo Foundation, which is based in Denmark. We're going to look in detail at the gene expression in steatocystomas, the idea being to try and find a treatment for cysts. And we're going to try and make cysts in a dish, is the ambition. And then we treat them. Sonja Lehmann is based in Aachen in Germany, and she has done work on mitochondria and PC. So mitochondria, as you may remember from school, are basically the energy producers of the cell. So in every cell, you've got mitochondria making ATP and producing energy. And the mitochondria in PC skin cells do not turn over normally. We don't understand why. It may indicate that the cells are tired in some way. So in summary, there's lots of research going on. The registry is very important and gives huge amounts of valuable information. And there are better treatments coming. I'm happy to answer any questions. You can put questions in the chat and I'll answer them while the further talks are ongoing. Thank you.
Thank you so much, Professor O'Toole. I'm too used to calling you by your first name. I'm trying to be very respectful here. But she's a very good friend, as is Professor Hovnanian, who is next. That was a perfect wrap up. There's things going on in the PC world, and I hope that you guys know that's what we're all about. I'm just checking our time real quick. Yeah, we might keep going. So if you have questions for Professor O'Toole, let's save them. We're going to have a physician and research panel coming up, and go ahead, maybe Professor Hovnanian, and you can start sharing your screen.
Okay.
Always give you the access. Have you given him access? Perfect. And as he's getting ready to share his screen, I just want to tell you a perfect way that the registry works together. so we have a patient, and go ahead, Alon, as much as you want to just start sharing. While you're sharing, I'll just say this. We have a doctor that, not a doctor, a patient in our registry who has Olmstead, and he and his, or not he, but his wife and his child were using this erlotinib. And he told me one day on a call about erlotinib. Actually, it was an email, and maybe Professor Hovnanian would have got to it anyway. I don't know. Maybe it was going to come along, but because of this patient that was in the registry that we had given a genetics to, he said, why don't you ask your people about erlotinib? So we talked to Professor Hovnanian, and he said, okay, let me check it out for you. And like I said, he might have done it anyway. It might have been a natural progression anyway. But the fact is, Professor Hovnanian got on a call with us, a Zoom call. I don't even know if you remember this, several years ago with Dr. Francis Smith. And we talked about this, and he said, okay, I'll go for it. And he did. And so this is a perfect example of how the registry patients work with the IPCC, the professionals. And with that, I'm going to turn the time to you, Professor Hovnanian.
Thank you very much, Janice, for your kind introduction. Thanks also, Edel, for introducing the scene of the subject. So I'm going to present the work we've done on the exploration of erlotinib as a treatment for Pachyonychia congenita. This is my disclosure. So this picture is just to remind you the general architecture of the epidermis, because I'm going to refer to the different layers of the epidermis. And the deepest layer is called the basal layer, where the keratinocytes, which are the epidermal cells, proliferate. And then the suprabasal layers are called the spinous layers and the granular layers. We're not going to talk too much about the stratum corneum. So, as you know, the detailed underlying mechanisms of PC are still partially understood only. And but it is obvious that there is a very abnormal keratinocyte differentiation. Researchers like Pierre Coulombe have demonstrated increased oxidative stress and dysregulated innate immunity. In addition, several labs have shown evidence for increased activity of mTOR. mTOR is shown on this cartoon, and mTOR is an enzyme which adds phosphate. It phosphorylates other proteins which make them active. And this enzyme is involved in, is one of the downstream effects of the activation of a molecule which is called EGF receptor, which stands for epidermal growth factor receptor. And this cartoon shows that it is a double receptor which binds specific ligands. There are at least 5 of them. And upon binding, this receptor becomes activated, and you see it activates at least 2 of these pathways, which you can, which are called mTOR pathway and the ERK pathway. And these both pathways are involved in cell growth and survival and angiogenesis. So Dr. Joyce Teng and Dr. Hickertson have previously shown that targeting mTOR by using mTOR inhibitors, such as sirolimus, is effective both orally and topically. And as you know, Palvella is running a clinical trial to further prove this. And it improves PC symptoms and it reduced pain. But we took advantage of what we learned from another rare severe palmoplantar crowdoderma that Edel referred to, which is called Olmsted syndrome. So Olmsted syndrome is not due to keratin mutations, but it's caused by mutations in this molecule, which is called TRPV3, which is a heat-activated calcium channel, which allows the entry of calcium into the cell, which further activates other molecules. For example, it activates ADAM3, which is a kind of SHEDAS. I mean, it cuts other molecules like growth factors, which then are detached from the membrane of the cell and which can activate EGF receptor. So you see there's a functional link between TRPV3 and EGF receptor. But TRPV3, because TRPV3 is mutated in Olmsted, we and other labs treated patients with Olmsted syndrome with an EGF receptor inhibitor, which is, by the way, erlotinib. And we showed a significant improvement both in pain and in callusis, which is shown here. And the improvement was very quick and sustainable. So based on these results, we thought, well, there's a link, there's a functional link between both molecules. So we should investigate in detail the EGF receptor pathway and the TRPV3 pathway activation in patients with PC. So this work was done in my laboratory by Justine Basset mainly, and she presented her work at the European Society for Dermatological Research in Amsterdam that Edel referred to a few months last month. So we studied 4 patients. As you see, they were genetically proven for PC, and 2 of them had missense mutations in keratin 16, and the 2 others had a mutation in the keratin 6A. They were all affected with severe PC, and we treated 3 of them with erlotinib up to 12 months now. And before treating them, we carefully investigated EGF receptor pathway activation. So to do that, we had to do skin biopsies, and these patients were very brave because they accepted under local anesthesia to have a lesional skin biopsy and a non-lesional skin biopsy. We also took skin biopsies from a normal healthy volunteer. And this first picture shows the level of expression of TRPV3, you know, this molecule which is mutated in Olmsted. It shows not the protein expression, but the expression of the mRNA, which reflects the expression of the gene. And you see that whereas in healthy control, the purple signals are very weak and they are quite rare, they are significantly increased in number and in intensity on the entire epidermis from lesional skin. And they are almost similar to normal control in the non-lesional skin. And this is a graphic representation. So we had expression of this, of TRPV, very strong expression of on all the epidermal layers in lesional skin in the 3 PC patients we studied. Sorry, in the 4 patients. Next, we analyzed the expression of the ligands which bind EGF receptor to activate them. And here, 2 of these ligands are shown, the expression of epiregulin and TGF-alpha. And you see, again, when you compare the level of expression of this ligand on lesional skin, it is very strongly expressed in the uppermost layers of the spinous layers and in the granular layer, whereas it is almost not detectable at this enlargement on non-lesional skin. And a close-up shows that it is really the upper layers of the spinous and granular layers which express this ligand. Same for TGF alpha. So next, we wanted to see, in addition to EGF receptor ligands, are the receptors themselves overexpressed? And there are at least four there are 4 EGF receptors. So these pictures show that at least 2 of them, EGFR1 and HER2, are strongly expressed, again, mainly in lesional skin. You see, most epidermal layers are positive for this receptor here, whereas in non-lesional there is increased expression in suprabasal layers, which is distinct from the healthy skin from a control. It's less pronounced for the second receptor we tested, and in very consistent to activation of the pathway, we could detect these 2 molecules, which are very, very good markers or indicators of mTOR. It's called phospho-RPS6, it doesn't matter, but you see this molecule is significantly increased in lesional skin and almost not in non-lesional, because this is background in the stratum corneum. It is moderately expressed in healthy skin. And in parallel, phospho-ERK, which is a marker of the second pathway activated by EGF receptor, also shows significant increased expression, mostly in the lesional skin. Even more interestingly, we could show that vascular epidermal growth factor was significantly increased here in lesional skin in comparison with non-lesional skin. That's interesting because we were wondering, how do these neurovascular formation form? Well, probably overexpression of VEGF contributes to this. And here we show hyperexpression of keratin 6, which is interesting because keratin 6 is an indirect sign of EGF receptor activation through transglutaminase 1 activation. So these results were very consistent with not only overexpression of actors of EGF receptor pathway, but they were proving that EGF receptor pathway was overactive. So based on these results, we treated 3 adult PC patients. I mean, 3 of the 4 patients for whom we did the skin biopsies. And we treated them with low doses of erlotinib and an average of 1 milligram kilo. And you see that after 4 months or 3 months of treatment, there is some discrete reduction of the callusis and the hyperkeratotic plaques. It is not massive, but it is real. It is more pronounced in the third patient at month 9. But what was, and it is more obvious on the inflammatory aspect, which is really improved at month 6 in this patient on here on the edge of his foot. But what was more striking was that one patient showed a significant reduction of the thickness of his nails, and also the general some of his toenails also reduced in thickness. But what was more important for the patient was a marked reduction in the what we think are neurovascular structures when you compare their presence before treatment and after 6 months of treatment. But in fact, the most spectacular effect was on the pain. And we assessed the pain as a clinician do using quantitative scores. And these curves show the reduction in terms the reduction of the pain visual score in terms of percentage of reduction of diminution. 100%. They all start from 100%, and you see that very quickly since the first week there is 40% or 60% reduction of the pain score, which continues to decrease during the treatment and which really remains very low. I mean, we have a 20% improvement of the pain score even now at one year of after treatment. The graphs have not been updated. When we scored the quality of life, there we get a similar reduction, of a quick and sustained reduction of the score. You know, these scores, the higher they are, the worse the quality of life is. So there's a quick and significant and sustained reduction. And same for Skindex 16, which is another way to assess quality of life. What was interesting was that we could specifically show that a specific foot function index was showing the same decrease. And what was funny is that when we represent the course of the pain in parallel with the course of the walking distance, we could see that the patients were walking an increasing number of steps during treatment, and that was completely inversely proportional to the reduction of pain. And that was true for the three children, for the three patients. So this is the model we propose because we think this provides a first level of evidence that when you inhibit pharmacologically EGF receptor, you improve at least pain and hyperkeratosis to a lesser extent. We think that we are blocking a positive feedback between EGF receptor and TRPV3, which contributes to, when there's no blockage, it contributes to mTOR activation, which as it is shown here, mTOR activates VEGF receptor, vascular epidermal growth factor. It also increases the key keratin players expression. It increases cell proliferation. There's here a specific explanation of why some of the EGF receptor ligands are increased. Is because one of the targets of EGF activation is this molecule, TSC1/2, and TSC1 and TS2 inhibits epiregulin transcription, and we saw that epiregulin expression was significantly increased. So by blocking this, the activation of EGF receptor results in increased epiregulin expression. This is why we saw such a strong expression of this EGF receptor ligands, which significantly contributes to activation of EGF receptor. So we think that this complex is overlap active and significantly contributes to the abnormalities which are seen in patients with PC. And what is important is that they are very sensitive to cell stress and to physical stress also, which makes sense. So we've shown that EGF receptor signaling is increased in PC palmoplantar keratotic lesions. We've shown that at least in the 3 adult patients, pharmacological inhibition of EGF receptor with erlotinib was well tolerated. The side effects were minor. and they led to efficient treatment of pain and hyperkeratosis. And we think that because the tolerance is good and patients are pleased, we should probably think on treating a larger number of patients in the context of a randomized clinical trial to provide more evidence that this could help patients. And it is possible that this pathway is also activated in other palmoplantar keratoderma. So this is, I wanted to thank Justine Basset and Lucille Marchal and Mathilde Bonnet-Desclos from the lab, who did all this beautiful work, as well as Janice and Holly and Sylvie Potier and the PC patients who will recognize themselves as they are listening to this presentation. And thank you for your attention. I'll be happy to take questions.
We're kind of running on time, but let's do this one question. Are there side effects of this treatment that we know of right now?
Yes, the most frequent side effect was diarrhea, or, as well as acneiform skin lesions and transient and partial hair loss. But at higher doses, which are used to treat patients with a certain type of lung cancer, there are many other side effects which have been described, but we have not seen them at these low doses which we have used. Side effects could include eye problems like eye dryness or blepharitis. They can involve nail problem, pain in the nails. They can involve skin erosion, skin blisters, which is very severe. So it's not a very friendly drug, but at the doses we used in the 3 patients we treated, it was quite well accepted and well tolerated. Sorry.
One more question, and then we're going to move on. Is a long-term treatment with oral erlotinib feasible?
We do think it is feasible, especially at low doses. The 3 patients have been taking 50 milligrams or 75 milligrams of erlotinib every day for a year now. And I think they are quite happy with the benefit on the pain and the significant increase in their quality of life. But we need to treat more patients.
Okay, thank you so much. And we're going to keep moving. And thank you so much, Dr. Hovnanian. Really appreciate all the work that's been going on, and of course the patients that are being studied. We're going to now have Ofer. You are next. There's been a lot of questions about Botox. We know some of our patients have been doing it. I think Ofer is probably the expert in Tel Aviv who has perfected this process for PC. So we're going to let him talk and tell a little bit about the Botox treatment. And Katie, just so you know, there are topical formulations of erlotinib in process. So hold on tight. That's something that's being worked on right now. So anyway, we'll go on to, we'll turn the time now to Dr. Ofer Artzi. Did I say your name right?
Yep. Yes. Can you hear me?
Yeah, kind of. Can everybody hear him okay? Go ahead and talk.
All right. So it is my great pleasure. I'm from Tel Aviv, Israel, and I will probably take the conversation into a different direction, more procedural. And I have to say that if I, why doesn't it move?
Hey, Ofer, the sound is really low. Is it possible to turn it up on your end?
Let me try. Can you hear now?
Still pretty low.
Pretty low. That's the maximum that I can take. You can't hear me?
We can hear you. It's just very low. Just feel free to yell at us.
All right, I'm gonna yell. Let's see if it moves. All right, just a second. I don't know why it's all right. Okay, so I have been treating a patient for the last 9 years, and I have to say my relationship with the PC project and PC patient began 9 years ago when I met this lady. Back then she was 24. You can see the medical history, and she was complaining about mainly painful focal thickening of the soles and toenail changes and hyperhidrosis. And it has been going for 15 years. So when it started when she was 12, 13. And you can see the clinical picture. And based on the family history and the histology, and afterwards the genetic analysis, she was diagnosed by PC. We started, and I think most of the patient, we started with several treatments. And I have to say the main complaint of Karine was pain. So she could hardly walk. She could hardly stand. And it was, this was really the main complaint. And we tried several medications. So I'm sure you all familiar with the different medications. We tried all that is known and was known back then, and with a very mild improvement, if at all. So I have to say that we tried in the beginning to kind of avoid the injection of botulinum toxin. You have to understand that it was a different era. We didn't have much knowledge. So in the beginning, we tried different measures, but it didn't help. And then we decided to go towards the injection of botulinum toxin. Back then, and I'm talking about 2010, there were only 3 publications supporting the use of botulinum toxin with different rate of improvements. Why it improves, I'm not sure we can still say, maybe because of the reduction of hyperhidrosis. We know that it reduces, it causes the disappearance of the blisters between the calluses and the skin. But probably there are different mechanisms. One of the mechanisms is it inhibits the release of substance P and other peptides, and probably it affects the neurogenic system. It inhibits the neurogenic inflammation. I'm not sure it is important why it works, but it was proven to work, but we tried to really do it better. So we offered this first patient, and after 2 months, she came back, and there was an improvement, but it was very, very mild. I'm telling you the story because, you know, it started back then. We improved a lot in the last year. So we know now much more about the procedure, how to perform the procedure, how to maximize the result. And I'm going to share with you our, I would say, current knowledge. But again, back to the story, she came back with slight improvement. We decided to go again. And then we had another 2 patients. And to make story short, between 2014 and 2018, we just tried. We tried to improve because it was in the beginning a very painful procedure. We did it under topical anesthesia. It was very difficult to perform because while injecting into the calluses, all the toxin was ejected. It was just going outside, so it wasn't getting in. The improvement was mild, and we had short-term results. It recurred after weeks to 2 to 3 months, And one of the problems is that we didn't have really data. And every time we had to argue with the government, because nowadays it is fully reimbursed by the Israeli government, but back then we didn't have any data to support the constant, or I would say the regular injection of botulinum toxin. So every time we had to argue, or the patient had to pay for the treatment. So between 2014, I think we improved a lot, and I will show you the improvement up to now. First, we understood how to perform the anesthesia, and you will see exactly how we do it nowadays. Second, we understood how to prepare the skin in order to be fully prepared for the toxin injection. We understood how to exactly inject the toxin, because if you inject it in a wrong technique, you won't have results. We understood the dose. In the beginning, we used different dose for different patients, and we used the described dose. So now we use really higher doses, and we have better outcome. We actually monitored the improvement, so we know what we can promise to our patient in order to really kind of monitor the improvement and to improve our treatments. We know the best intervals, and we know the remission. Few words about what we know so far, and I will show you the data so far. Again, we improved a lot within years. So we know now that if you want to be treated with botulinum toxin injection, you have to maintain your, I would say, fit preparation actually on a daily basis. So every day, our patients are recommended to do some pedicure. There is some automatic devices that they buy, and every day they use it. That we have 2 phases preparation, 3 to 5 days prior to procedure, and another pedicure, which is just the day of the procedure or 1 day preceding the procedure. While doing so, you can really use the full dose, so nothing is getting out, and this really maximizes the result. We have an anesthesiologist. He's really that's what he does. He really knows how to do the anesthesia for our PC patients. And during the years, we tried so many techniques of botulinum toxin from different angles, with different needles, from outside to the inside, from the inside to the outside. So I can tell you nowadays, we know exactly, and I will not get into details, but we know now exactly how to do it for different patients and which doses should be used. So again, I will not get into details because this is really professional, but we know that for every patient, you have to find the trigger points, so the points of maximal pain, and those points should be treated in a different way as compared to the surrounding area. The surrounding area are treated from the outside, inside. But again, I think the main message is the dose. We start with 200 international units, and I'm talking about botulinum toxin. Again, I do not know the toxin in your country. I'm talking about the old Botox, but this is just the beginning dose from which we increase until we see a response. And then we maintain this dose, or we even increase the dose, and then we can maintain the result. Now, in order to convince our government to see exactly what are the improvements and how often you should really perform the procedure, during the years, we performed kind of a retrospective analysis. Back then, we had only 5 PC patients who went over and over, so they were treated again and again. In order to really deduce, we took all data. Again, I will not get into details in the sake of times, but all data of the treatment parameters, the demographics, the genetic data, the changes, so which parameters were changed and which parameters were not changed, in order to really understand. So for you to see how we did it, first, they had to score the parameter. For example, the morning fit burning before treatment, when it was improved, and what was the maximal improvement, okay? And then we had to monitor, I'm sure you're familiar with the PC quality of life questionnaire. So we wanted to see which interval is the best interval to treat our patient. So for example, we saw that if we treat our patient quiet, you will see in a second the intervals. I don't want to show it in advance, but you can see that, for example, we can promise a very dramatic improvement in the long distance walking, in the morning fit burning. But for example, the sweating or the calluses, they're not improved or they're improved to the least, to the extent as compared to the other parameters. We showed that if you are treated again and again, then all symptoms are improved and are maintained. So even if you have exacerbation, still there is an improvement, and it is very valid for the PC quality of life. So you can see if you're regularly treated by botulinum toxin, you will see in a second how often then your quality of life is improved and maintained. How often? This is a good question, and we checked it from different angles, and we use different statistical tools. You can see if you want to maintain the high quality of life, if you want to still maintain all parameters, you have to treat your fit, so you have to be injected below 100 days. And nowadays, this is the standard of care. And because of this publication, you can read all data in this publication that came out it was 2020. And now we know more. So this is the reason we don't wait for the calluses to get back to the original state. We don't wait for the symptoms to recur. We treat every 90 to 100 days, like a clock. And if we do so, we really have good result. So the take-home message in this, again, this is nearly 10 years of experience, 9.5 years of experience since I first met Karin. We know now, and now we have 10 patients. They are treated every 90 to 100 days. Actually, before the reappearance or the recurrence of the calluses, we know exactly how to prepare the skin. We have a very, nowadays that we are so used to it, it's every month we have scheduled anesthesiologist who come, and he knows exactly how to do it. It works as a system. We know the technique. We change the technique. We know the exact dose. We know how to do it. And while doing so, we really maintain our the life quality of our patient. And again, back to this amazing girl. Nowadays, she's about to get married. So I think this is the message And nowadays, we know we are part of many clinical trials, but I have to say that still I can see how they come on the first day when they are diagnosed, and I explain about the process and about our long-term relationship. And we can see that after a year, and it gets improved and improved, it's worth the efforts. It is really worth the treatment. And again, it improves the life quality to a very, in all parameters are improved. So I hope you could hear me.
Thank you so much. Really appreciate that. There's been a lot of interest in our community about this. One question for you: does the relief continue to last even with recurrent injections, or do you find the symptom relief get shorter with repeated treatments?
It's a good question, because not all patients actually experience the same. So we have patients in which while injecting every, let's say, 90 to 100 days, for example, Corinne, it is really maintained. But we do have 2 patients in which we had to shorten the intervals. But again, you have to think about the future. There was just recent FDA approval of another botulinum toxin. This botulinum toxin will have a longer duration of action. So it's still, we do not have it in Israel so far, but again, understanding I would say the improvement with the non-botulinum toxin, maybe in the future, while having botulinum toxin with longer duration of action, then, maybe we will be able to perform the treatment every 6 months. Because, for example, the current, so the last FDA approved new botulinum toxin, they talk about life duration of 6 to 9 months, as compared to 3 to 4 months of the current botulinum toxin. So again, this is a new and interesting, and we can see the improvement. So the improvement, there is no question. Again, there is a variability. Not every patient is improved to the same extent, okay? And we are different. So this project is amazing. You are patients from different countries, but in the end, although you all suffer from PC, you are different mentality, different personalities. Everyone has different, I would say, preference. But again, if I talk about the average PC patient, and I'm talking about our experience, this is only 10 patients, but every 3 months for let's say 10 years. So have the calculation how many treatment, we can see the improvement. And the improvement, when I'm getting it nowadays, every, let's say, every month I have one WhatsApp of a PC patient who finished a marathon, okay? Of a PC patient who is telling Corinne, she sent her video. I was asking her, and then I got an invitation for a wedding, and she was telling me about how she's happy that she will be able to stand. You have to understand, while coming back then, around 10 years ago, she couldn't really stand. She came with a wheelchair. So again, this is a treatment that work. In the future, I'm sure we will have better toxins. Now you have better drugs. Maybe they will be able to be combined with the injection of toxin. But again, the future is brighter. And this is maybe the main message.
Fantastic. Thank you. Ofer, are you able to look at our chat?
Yeah.
We have a lot of questions in the chat. How do you feel about answering them in the chat?
Yeah, I'll try. Okay, I'll do my best. All right,
Because
I'll try.
there's a
Let's-
lot of interest. I just worry about the doctors that need to keep going, but there, you can see, is it possible to develop a resistance for Botox? How long does the whole procedure last? People want to know, how do you start getting it? So we could take another 30 minutes, I think.
yeah,
Guys,
it's
this
a-
is the beauty of the in-person patient support meeting. It lasts a day and a half. So,
Yeah.
so thank you.
Maybe Janice, just because there are few ones which I will do it just shortly. Does it reduce the calluses? The answer is no. Okay, how does one even go about getting Botox if the vast majority of doctors? This is a problem. This is maybe we have some seminars from doctors who are coming to learn how to do it. It took me and my staff really 5 years to know how to do it. And I learned, it's maybe bad to say, but I learned it over the back of our patient, because in the beginning I didn't know how to do it, because I knew how to inject botulinum toxin for hyperhidrosis, but again, you can just make the connection. If you have a physician who are willing to learn, just give him my email address, my contact, and I promise for free to do the teaching, or at least to teach your physician. Is it possible to develop resistant? Look, resistant for botulinum toxin is described in every discipline, not just for PC patient, but it's rare. We have one patient in which we thought we might see a resistant, and then we change from Botox to Dysport. So you have different types of botulinum toxin, but this is really, we can really deal with it, okay? But this is really like high end. How long does the whole procedure last? Nowadays that we have such a great system, there is 10 minutes of nerve blocks, okay? And then it takes me 5 minutes, and then another 1 hour that we talk and hug and laugh, because my PC patient, they became my really good friends. So it's mostly talking, okay? But the procedure is approximately 20 minutes altogether. If your doctor, dermatology agrees to do injection, they can order the medication. Again, in Israel, it is fully paid by the government. We convinced all the authorities that this is really a medical condition. This is not an aesthetic wrinkle condition, and it is reimbursed. So we provide the medication. They just have to come. If my pediatrics has never heard of, so again, give him my email address. I promise to let him know. Safe,
Okay.
it's really safe. And to carry on, Janice.
Yeah, I'm so bad. I'm just worried about our time, and the questions keep coming. So if you don't mind, Ofer, just start chatting away here.
All right, I'll do my best to start.
The other thing is, no, this is so great. What we'll do is we're also going to save these. And if you don't get them, we might just send you the questions, and then and then you really have a chance to answer. I think we could spend a lot more time here. I am so sorry. I wish we had all the time in the world, or maybe everybody's okay. But I think just keep going.
Just one sentence. Send everyone, or I can send you, and you will send everyone. There is this paper. This paper is really describe all the advantages, the technique, the dose. This is a paper to begin from. Give it to your dermatologist or pediatrics or any physician. This is first. And again, if they're not convinced, I will write in the chat my personal email. You're more than welcome to send me a question, or your physician can send me a question, and I'll do my best to answer. But again, this is a very beneficial treatment. And with the newer botulinum toxin, with the ones with longer duration, there is a hope, okay? And then if it's twice yearly injections, I don't know, this is a good solution.
Thank you so much. Clearly interest. Appreciate you so much. Feel free to chat away. We're We were supposed to have a break. Everybody, do you need a break or can we just keep going?
Keep going.
We're gonna keep going. We're just gonna keep going, guys. And so, Dr. Funk, the thing that I think a lot of people are very interested, what? Picture first? Oh, you know what? Holly's reminding me. Ofer, if you want to stop sharing your screen, or maybe it's just my, might just be my,
No,
oh, it's just me, sorry. It's me. Can everybody, if you want to be in a picture, I just have my picture up, so I see Ofer really big, which is great. You look awesome, and your bike is awesome looking too, by the way. Exactly, a PCer's best friend is a bike. We all love them. If you want to just take a minute before Tracy shares her screen, everybody take a look. If you want to turn on your camera, we're going to have a group picture. So everybody smile into your picture, and everybody just, yeah. If you want to turn on your camera, smile, and Holly will start screenshotting you like crazy. Ah, okay. Just when you're done.
well, then people are still coming on as well.
Jean, you got a light in the back. We gotta wait for Jean.
You are too black. Surely you are too black.
The Sharda family. Or good, Holly? Okay, we're good. Okay, we had a nice slideshow. Maybe we can show you it at the end. But let's keep moving. Hey, thanks you guys. You're awesome. We just love to, this is as close as we're getting. So this is the update of the Palvella clinical trial. This is Dr. Funk. She is out of Oregon, and there was a lot of interest in the clinical trial right now that's going on. So Tracy, we're going to hand it to you. Thank you so much. And yeah, I just wanted to know that we want lots of options for our patients, and we're so excited to be this far along in a clinical trial for PC, a potential treatment. So here we go.
Yes, thank you so much for having me. Can you hear me okay?
We can hear you.
All right. I'm Tracy Funk. I'm a pediatric dermatologist from Portland, Oregon, and I'm excited to be here with you all today. I love that I got to see you all on screen prior to this talk, so that was wonderful. So today, Jan and the PC Project have asked me to talk a little bit about the background of clinical trials. How do they work? They're kind of mysterious, I think, to a lot of people. And then also to update everybody on how the Palvella trials in particular are going. So this is a little bit of a busy slide, but this is kind of an outline of clinical trials and research that leads up to clinical trials. They are a very long process. Getting a medication approved by the FDA is an extremely expensive, long process for pharmaceutical companies. So this kind of outlines that process. What typically starts is that there is a researcher or scientist or someone at a pharmaceutical company who discovers a drug that they think will be effective or helpful for a condition. And that then goes through a lot of preclinical testing. So prior to the clinical trials, people are doing a lot of studies or testing. Sometimes it's physicians that try a new medication for a new condition. This varies quite a bit. But once we see that there may be a medication that might be helpful for a condition, a drug company may then move forward with clinical trials. And so you'll see in pink down at the bottom, phase 1, phase 2, and phase 3, that's the clinical trial section. In phase 1 of clinical trials, drug companies are really usually looking at, is this medication safe in humans? That's the main goal of a phase 1 clinical trial. And so patients who participate in phase 1 trials get a lot of blood samples drawn, and they often have a lot of testing and maintenance and reviews and things like that to make sure that the drug is safe. It then moves on to phase 2 clinical trials, where pharmaceutical companies are looking at safety and efficacy, or how effective or how well that drug works. And then in phase 3, often a pharmaceutical company will be looking at a bigger group of patients, or sometimes at different doses of a medication. to see how well it works at different doses or in different patient populations. If the drug does well in all of those phases, and it looks like it's both safe and effective for patients, then that drug company will take the medication to the FDA. And there's a specific group at the FDA called CDER, the Center for Drug Evaluation and Research. And they have a team of scientists and physicians and pharmacists who review all of the data. They review all the safety data and all the efficacy data to make sure that they think that that drug will be helpful, and then it either gets approved or not. So that's the background of clinical trials. And so what has Palvella's role been? So Palvella has, they have created a formulation of a medication called sirolimus. Sirolimus is a medication that has existed before Palvella created the gel. Sirolimus is an oral medication that's already been FDA approved for the treatment of various other conditions. But what Palvella did was they took that medication and they turned it into a gel for the use in Pachyonychia congenita patients. Based on, I think I heard the end of Dr. Havnanian's talk, and I know he talked about mTOR a lot, and so you all have that kind of background. Based on its effect on mTOR, we think that if we can decrease the keratin production of the keratins that are changed in patients who have Pachyonychia congenita, if we can decrease the production of those, we can decrease skin fragility and pain. And so Palvella has created this 3.9% sirolimus gel. And then they have been trialing it in clinical trials. And recently, the FDA has approved testing in patients down to 13 years of age. So that's a great sign that the medication seems to be very safe. So here's a look at the ongoing Palvella trials. So as I mentioned, sirolimus was a medication that had already been approved. It was already on the market. And so Palvella didn't really have to do a lot of that background research that was already done. But they did do some preclinical trials of the gel formulation to make sure that that would be safe in humans. And then they took it into clinical trials. So phase 1, phase 2, and phase 3 trials, you can see down at the bottom. So they had the VALO studies, which are now completed. And you can see above that phase 3 clinical trial there, they have the VAPOS trial, which is an ongoing clinical trial currently in phase 3. And here's a chart form of the clinical trials that they've done. You can see 4 trials listed here. The top 2 have been completed, and we'll talk briefly about those, although I know that you've had updates on those in the past at these meetings. Currently, the VAPOS trial is in phase 3, and that's fully enrolled, but still going on. And then there's a new study that Palvella has announced, their open label study, which will be an ongoing safety study, and I'll talk briefly about that as well. A lot of people ask how they're measuring how effective the medication is. And so they use many ways of measuring how effective this medication is. If you've been part of this study, you'll all remember the Patient Global Assessment of Activity Scale. That's what you enter on your phones every day. It's kind of a diary where you can log your activity level. And that was created specifically for patients with Pachyonychia congenita to help measure if this drug is going to be effective or not. They're also looking at pain at its worst. They look at the PROMIS score, which is a measure. It's kind of a standardized measure of how patients are feeling and their activity or what they're able to do. The clinician global impression of severity and change. And so that's when your physician that's doing the clinical trial with you brings you into the office and they talk with you. For me, it's I talk a lot with my patients about what their activity has been like since I saw them last. How many stores can they walk to at the mall? How many holes of golf are they golfing? How are their feet feeling at the end of the day? Are they needing to crawl or use assisted walking devices and things like that? And then, of course, they're measuring safety in these trials. And so here are the results of the completed Palvella trials. As I mentioned, these have been discussed at prior meetings, so we won't spend a lot of time on these, but just a reminder, the VALO studies were a phase 2-3 trial. And it was a 6-month trial overall. And in the first 3 months, it was a phase 2 trial where all of the patients received this topical sirolimus called Qutoran. And all of the patients were treated. And then after that 3 months, patients were separated into 3 groups where one group received the medication once a day, another group received it twice a day, and then another group received just the vehicle or a placebo. And that's where the results got a little bit difficult to interpret, was in that phase 3 trial. And so I think Palvella feels that maybe that study design made it hard to interpret that phase 3 trial. And so that's really the biggest reason for their next phase 3 trial, which is currently ongoing, is to help answer that question: is this effective or not? So the big question, of course, is, does QTORIN 3.9% gel work? And that's really what this clinical trial is looking at. So patients in this current phase 3 trial, unlike the last trial, have not all been treated with the gel. So from the start, patients were randomized either to receive the medication or to get placebo. And so we don't know who's getting medication and who's not getting medication. And we'll be able to compare the results at the end of the trial to see if this was helpful or not. So hopefully that makes sense in how those two trials were different. I did just want to mention their new open label study. This will be a trial that's ongoing. It's currently enrolling. So for any patient who completes the phase 3 VAPOS trial on or after November 15th, so just 4 days ago or later, will be eligible to enroll in this ongoing safety study. This will be a study that will be necessary when Palvella submits their new drug application to the FDA. They're going to want this long-term safety study, this 6-month safety study. And so they're currently enrolling these patients. All of the visits will be remote except for one where they're planning to do a blood draw. And all patients will receive medication, and there's no daily diary in this portion. So just a quick recap of some of the questions that we've received. When will we know the results of the current phase 3 trial? Results are anticipated from Palvella in mid-2023, so that's summertime. Hopefully we'll hear then. After the phase 3 trial ends, what happens next? After the phase 3 trial ends, what happens next? That would be hopefully when Palvella submits their data to the FDA for a new drug application. What if phase 3 data shows that it doesn't work? This is a really difficult question to answer because I think there are a lot of potential outcomes. Maybe the medication works in some patients, but not all patients. Maybe it works, for more mild or more severe. There are so many potential outcomes, or maybe it works for everyone. We really just don't know. And so I think we just have to wait and see what the data shows. And then, do some drugs work for some patients and not for others? And this is absolutely true. I was trying to think, after somebody asked me this question, if I know of a single medication where it works for every patient in every condition, or in all of the patients who have the condition. And I don't know of any medications that work for everyone. So probably won't be 100% effective. And I just wanted to say thank you for all of the patients who participate in clinical trials. It's really eye-opening as a physician for me to see how necessary it is for patients to participate in order for new medications to be approved and to be discovered and to be out there on the market and in use for patients. If patients didn't participate in clinical trials, we would not have new medications to use. So thank you to all of the patients. And I can take questions if there are any.
Maybe we're okay. This is good. Thank you so much, Dr. Funk. We did have a few that came in. I wanted to know if this works, will it apply to children? And Palvella recently received communications from the FDA allowing dosing for children as young as 13 years old. So that's the answer on that. Some of them asked about nails. Does it improve the nails? Right now, in the clinical studies, it's applied only to the soles of the feet, not to the nails. And so it works in the skin, but they haven't tried it at all on the nails, but I don't think that's how it works. Another question was, does the drug work well on pain? That's a great question. This is one of the secondary endpoints that the clinical studies look at. And the primary endpoint looks at the difficulty of function while on the feet. And now that some of you have asked, if you're in the trial right now, will you get to learn if you receive the placebo or not? And the answer is yes. After the study is unblinded, once everybody's been through the study, they'll find out, did it work? Did it not? And you'll get to know, you'll be able to talk to your principal investigator or the doctor who's at your clinical trial site. One last question is, people in the previous phase 2 trial have asked repeatedly, can we get back on again? And right now, the FDA has told Palvella that the only people that can have this are the people that were what they call it treatment naive, meaning they never had the drug on it couldn't even touch their toes. And so so only those people can be in these trials right this minute. But the company hopes that sometime next year that they can start inviting these treatment experienced patients back into the program, outside of purposes of gathering efficacy data. I'm reading that part right there, word for word. So I know there's been a lot of interest in this trial. And like Tracy said, I hope that you can see just even from today that our goal as PC Project is to give you options for treatments before we have the cure. I was listening to a talk about Castleman's the other day, and they told us that about a third of their patients are being treated with one drug, another third are being treated with another one, and then they're still looking for the third one, and the drug for the third group of people. So I'm not a doctor, I'm not a scientist, but we'll let the data speak for itself, and just want to reiterate for the people that have tried the Botox, people who have tried, the erlotinib, the people who have tried the clinical trial, who are in the clinical trial right now. It's just so important. And we're just very grateful to all of you for your interest. We have such a fabulous community. And with that, I'm going to turn the time to Dr. Dave Hansen. He is the PI of our registry. That means the principal investigator. And we're going to have, you guys submitted a lot of questions, and we're going to turn it to you, Dave, for pretty much an open session. And just wanted to let you know, I can see that we have 2 other doctors on our team that I didn't realize were going to be here. We've got Joyce Tang and we've got Angela Hernandez. At least I think I saw them. So just not to put either of you 2 on the spot. Oh, there's Angela right there. We've got Benjamin Names. We've got Ellie Sprecher, Adele, Alon. So just wanted to let you guys know, Dave, you're in charge of this part of the meeting, but wanted to let the rest, all of you, Al Bravo, our resident podiatrist. It's not my job, Dave, this is yours, but I just wanted to let the others know that you're welcome to pipe in if you have something inspiring to say. Is that fair enough to say, Dave?
Absolutely. Can you hear me okay?
Sure.
Does that come through? Okay.
Yeah.
As I reviewed the questions that were submitted, many of those questions have been discussed and answered in our discussion already this morning. So that's wonderful. There was a quick question about if the medication is approved, how soon does it, or how does it get distributed? Like most medications, it's distributed to pharmaceutical companies, and then insurance will talk about the cost and so forth. But that's a decision that will take place after approval of the medication. The current Palvella trial is being conducted in the United States and in England with Dr. O'Toole, and they were wondering about trials in other countries. And most countries have an FDA-like organization that controls clinical trials, and so they have to apply to be in those countries. And to keep it simple, they've tried to reduce the number of places where they're actually doing the trial, because it's easier to actually get good data if you can control where it's happening. So it's in the United States and it's in Great Britain. And so for future clinical trials, they may go to other countries as well. Looking at questions, one of the things that was talked about was a lot of questions about the management of pain. And let me just have maybe Adele or one of the other ones on the panel, and we have Dr. Sprecher and Dr. Hovanian, as well as Tracy, talk about just briefly about they went on about the age of onset of pain, and then about progression. Does pain get better or worse over time? And so Adele, if you're still on someplace, do you want to talk for a minute about the natural history of pain in PC?
So pain generally becomes a problem in the teenage years. So the calluses start to appear when the child starts to walk. And this can vary in severity, but I would say in general, pain becomes a problem in the teenage years. This can vary. So in keratin 6B, for example, or keratin 6C, it might be a little bit later, 16, 17, but I would say in a patient with keratin 6A or keratin 16, it would generally be a problem by the age of 11 or 12.
How about progression?
Yeah, I mean, I think that can vary a lot. I mean, pain is a very subjective thing. So I think, you know, in general, I would say it probably gets worse over the teenage years, and then it sort of plateaus. But you know, things can happen in people's lives, and the pain can be worse for various reasons. You know, so sometimes if people with bad PC or even moderately severe PC have imbalance in their walking, for example, and they can get other pains in their knees and their hips and their back. So you know, it all, and then that makes the pain in their feet worse. And you know, so there's sort of a series of events that can change what happens to the plantar pain. And then if somebody obviously has an infection or a blister or whatever, that will make it worse as well.
And I agree. My experience has been that as people get older, they learn to adapt to the pain. They know what creates pain, and they avoid those activities that increase the pain. And so there's kind of a plateau. And as Jack was mentioning, there's a bank of it's pain bank. And people understand what that pain bank is and what they can do and what they can't do.
Yeah.
And so that's variable. But I don't see a uniform progression to worse pain over time. So it seems that it persists. It certainly doesn't go away, but it doesn't necessarily get worse over the course of time. So there was an interesting question that one of the individuals submitted a question saying that they had been put on prednisone for another unrelated condition, and that their PC pain had improved while they were on the prednisone. And one of the things that we talked about with Dr. O'Toole and Dr. Hovnanian this morning is that inflammation may be playing a role in the generation of pain in PC. And so that people have been looked at sort of medications that have anti-inflammatory characteristics like this epidermal growth factor receptor blockers, even Botox can sometimes fit into that category. As well as then JAK inhibitors. Ellie or Adele or any one of those, do you want to talk a little bit about inflammation and how that may relate to treatment of PC?
I mean, I think that in the past, we were used to consider different physiological systems as functioning independently. So there was inflammation, was pain, there was regulation of tissue growth, and all these different processes were seen as occurring and being regulated independently. Now we understand that part of what is, for example, regulating the proliferation of the cells, which are at the end building up our skin, is shared by processes which are also regulating inflammation. And inflammation is strongly related also to the production of all kind of molecules which are mediating pain. So everything is actually interdependent. And that's why when you treat inflammation, you may actually also treat pain and diminish the tendency of the skin to overgrowth. And the same paradigm is also existing in other genetic skin diseases, such as epidermolysis bullosa, for example. So that targeting inflammation is now considered as something which may actually affect different processes, which are all contributing together to what is actually perceived by the patients as the major consequences of their disease, and that might be pain, or the calluses, or the feeling of what is sometimes called infection, but very often may just be inflammation and not true infection.
Good summary. And one of the things that just to emphasize is that we don't think that oral cortisone medications have a long-term benefit in terms of PC, that they may temporarily reduce inflammation and make them feel better, but it's certainly not something we would suggest that is used as a long-term mechanism for control. There's a whole group of new medications that are being studied, and that's one of the exciting things that is happening in the PC community, is we're looking at a number of new molecules that may have an effect in PC, like they did in Olmsted. Dr. Hovanian talked about the Olmsted situation and the impressive result they have with oral ilatinib. I would just add that oral ilatinib may have some long-term concerns, and whether that's a long-term management issue is still waits to be determined. Any other panel experts on inflammation and products? Anything to add to that? Let me ask a second question then, just to the panel. One of them had mentioned that neuropathy is one of the things that people experience pain in the lower extremities. These are diabetic neuropathy or things of that nature. There are medications that are used to try and treat neuropathy. Do we have any experience to say whether those medications might also be effective in pachyonychia? And anyone from the panel that has an idea about that, or particularly even topical medications that are used sometimes in neuropathy, are they helpful in PC? Any thoughts?
This is Joyce, and I just want to make a quick comment. Some of my patients do take a Neurontin, and some of them feel like it doesn't take the edge of the pain when they have acute to really severe pain. However, it tempers their baseline to a certain extent. Of course, the medication has side effects. They tend to make people feel a little fatigued, a little more tired, and sometimes on a higher dose, they feel like their thoughts are a little cloudy and a little drowsy. So those are the potential side effects. You do have to balance that. There are some topical preparation. All dermatologists probably use them in the clinic. And when you have acute blistering, for instance, some topical steroid to reduce the inflammation, and as other panelists discussed, that it could be potentially helpful. But other things like cooling down the skin, for instance, using a sauna lotion or capsaicin, for instance, is something that some of my patients also use, and also helps to a certain extent. And the other thing about neuropathy is that, I recently encountered a couple of patients, when they have blister, people tend to walk, even though they were in the shoes they used to wear, but they walk with a different gait and to try to avoid the pain. And when they walk with a different gait, and it really hurts their ankle and it hurts parts of their foot. It depends on how they walk. So even if you don't see a podiatrist, you don't see a physical therapist on a regular basis, it might be helpful to get a baseline evaluation about how you should walk and to get some input. And when you have pain, how to alleviate the pain, to just have that self-awareness, I find to be quite helpful. And to reduce the blistering, of course, that aside from inflammation, sometimes it's just a mechanical stress from ambulation, from overwalking. But the other thing that we have to think about, when your skin barrier is not intact, there's some, you heard from previous speaker, there's some research going on about bacteria, microbial live on the skin, and those microbial living on the skin can really increase the skin fragility as well. Sometimes it is infection, and sometimes it is just colonization. And to bear in mind, if you're doing the regular routine skincare that it's not working, maybe think about, do I have some, especially during the summer in a moist, humid climate, whether there's a situation that there's some overgrowth of bacteria on your skin, and you can try to decolonize it and reduce that bacterial loads, and that may improve the skin durability.
That's a great summary. Jen, we almost might take and try to summarize some of that in a different publication because there were lots of ideas that could be explored that Joyce has mentioned. Excellent thoughts. Anyone others from the panel?
Al Bravo
Dave,
would like to speak, I think.
Yeah.
It's Al Bravo. I just wanted to echo what Dr. Tang said as far as the mechanics of the foot playing largely into that. That's a huge topic. It's probably more time than we have to go through now, but I think that's pretty paramount. But also, as far as topical medications, I think that in PC patients who are prone to blistering with a degree of hyperhidrosis, topical dry sol can be pretty effective in reducing the blistering and reducing the pain there. And for the patients who get those neurovascular lesions within the corns or calluses that are so exquisitely painful, we've had really very significant improvement using topical silver nitrate. And for the patients who may not be aware of that, it looks like a matchstick, and the head of the matchstick is this medication, silver nitrate, and it seems to sort of locally cauterize those little nerve endings and the little blood vessels, and it's pretty dramatic in the reduction of pain from those neurovascular lesions.
Excellent. Other thoughts? We're going to come back to you in a minute here, Al, with some new questions. Couple of things I was curious about. We had Tracy talked a lot about the Palvella trials, which have been wonderful. Dr. Funk also lives in Oregon, where CBD is heavily used. There were thoughts about CBD using to modify pain. Tracy, do you have any comments about that or any experience with that?
That's a great question. Definitely, we have a lot of patients who try it. I have patients with a lot of conditions who try CBD for pain or for other issues. And it's hard because it hasn't been studied really in clinical trials. And so I think that the jury is still out.
Other thoughts from others on the panel about use of CBD? I know several individuals in their questions and so forth have indicated they do use CBD and they think it's helpful. We have no good clinical studies comparing how effective it is and how it should be used. And so there's still a question that's needs some additional information. Other thoughts?
Yeah, I've certainly seen patients who use cannabis, weed, smoke weed, or drink alcohol for pain relief.
So we published several anecdotal cases in epidermolysis bullosa simplex patients. And as some of you know, that epidermolysis simplex patients can also have a painful keratoderma on the bottom of their feet due to a different type of a keratin mutation. They have keratin mutation of 5 and 14, and a few patients that seem to have some improvement. There is there are 2 ongoing clinical trials that looking into the effect of CBD. The problem in the US and many other countries is that most of the people getting them from compounding these distributors, the quality is very inconsistent. And so the active ingredients, concentration, and the vehicle itself are very inconsistent. So that makes the an objective evaluation about the efficacy of this treatment to be very, very difficult. So just something to keep in mind.
That's a great summary. I would agree, Joyce, that there's no consistency in terms of manufacturing like there is usually with pharmaceutical products that are FDA approved and purchased or used by a specific company.
Maybe just a short note aside, I think that there are also some data showing that cannabinoid may affect epidermal differentiation, especially of the hair follicle. And that, of course, may have also some impact. I mean, besides using cannabinoid to relieve pain, in the context of a keratin disorder, it may also actually have at some point some impact. This is something which has never been studied in the context of a keratin disorder, but it is known that cannabinoid have an effect on epidermal differentiation and hair follicle differentiation as well. So that may be relevant.
Interesting.
Due to
Another
the,
possible mechanism.
Yeah.
To do that. Something that at least it's out there and needs to be looked at more closely over time. And so we hope to get better data as we observe those kinds of things. One of the questions was about nail changes, which all PC patients have some degree of nail changes, particularly on the feet. And Al, if you're right there, they wondered about how best to manage the hyperkeratosis, dysplasia in the nails. And secondly, particularly with teenagers, how you can camouflage or kind of hide those changes in nails. Any suggestions with how they might manage changes in the nails?
Yeah, I think that a lot of the changes in PC nails are often confused, or they can certainly coexist with onychomycosis, which is a fungal infection of the nail. I think a lot of the people probably have a little bit of both going on with that. I'm not sure that topical antifungals are really going to be super effective, but they may give some degree of improvement. There's oral antifungal medication that can be taken that would help the thickening and the discoloration due to the fungus, but you're still going to have the residual nail deformity caused by the PC process. I think that if the nail deformity is severe, I think having them professionally taken care of periodically, maybe every 6 months or something, would keep them down enough where people would be able to take care of themselves at home. What I recommend when I see people with the nail changes that we treat in the office professionally, we get them down pretty good with our instruments, is that they just hit them like once, even if they're not thick yet, hit them once a week with an emery board just for a minute, just to keep them down. And I compare it to how they mow the putting greens at a golf course. They mow them every day, so it never gets long. So once the nails are down pretty well, if they just maintain it with an emery board, I think that's pretty effective. And then we have a lot of people, they just, once they're down like that, they just put on the standard nail polishes and stuff and you can really get them looking reasonably good, I think, that way.
I think it's a real issue particularly for kids and teenagers. People look at their nails and wonder what's happened and so forth. So those are good suggestions that are helpful in terms of how to manage those nail changes.
Dave,
yeah.
I know I'm not a doctor. I just want to make a comment too, especially if there's parents on this call, that when the nails get trimmed or when you're trimming your child's nails, it should not hurt. There's a lot of variance in the kinds of nails in PC, and some can get trimmed down more than others. But just keep that in mind as you trim. It should not hurt. If it's hurting, you're hitting something live. So just be careful. I have to say that because I hear about too many kids that get tortured and I can't stand it.
That's one of the, and I agree 100% with what Jan says, but that's one of the benefits to using, instead of a sharp instrument, having the patients use like an emery board or something very, very regularly, as opposed to wait till they get thick and try to cut them with a sharp instrument.
One corollary to this is that, in my experience, nail infections are a rare event with PC. Almost every PC patient that's seen by a physician says, "Oh, you've got fungus in your nails." And in my experience, that's a rare event. And before taking oral or topical antifungals, if you have PC, I would want to know that you can actually culture or see that this is actually a true fungal infection before you treat it.
Absolutely. One other thing I should just mention, and I actually had this done on myself, is that if the nail deformity is very severe, there's procedures that can be done to permanently remove the nail, and then basically kill the nail root so the nail doesn't grow. And I had that done on probably half of my nails, and it's very interesting because prior to having it done, the nails were really, really painful. They weren't ingrown, but they were just painful from the thickening and the whole PC process. Once they were removed, something grew back. It's sort of nail-ish like, or thick skin-ish stuff, but the pain's completely gone, which I thought was pretty interesting. So if somebody sees a doctor and say, well, these can be removed permanently, in my experience, it helped tremendously with the pain, but there still is regrowth of tissue there of some sort.
Al, while you've got the podium there, talk a little bit about, there's lots of questions about choice of footwear. Are there specific shoes that are more amenable to improving the pain? And along with that are inserts or insoles or so forth in shoes. What's your opinion about what would be most effective and how that works?
That's a great question. And we could probably talk about that for several hours, but a couple of things that I would mention as sort of general principles. In general, for most, and again, I preface this by saying what has been said before, the PC experience is variable from one person to another. So what might work very well for one person may not work at all for another person. But in general, what I find is, and this might be contrary to what people may think, but a stiff-soled shoe that has a bit of a rocker configuration, in other words, the sole of the shoe isn't completely flat, it sort of goes up at the toes a little bit, tends to be very helpful because the shoe itself will help the person propel forward without getting as much pressure or friction on the skin. So whereas a very soft, flexible shoe, which might be attractive, you can say that's really cushiony, but that has a lot more shear forces within it, and that can lead to blistering and discomfort. So what I find is a stiff-soled shoe with some rocker configuration. You need to have some degree of cushioning, but too much cushioning can be counterproductive. So you got to be careful, I think, with that. The ventilation of a shoe is also really important. And fortunately now it's pretty easy to get a good walking shoe or running shoe that has very breathable uppers. So if the foot stays cooler, the perspiration tends to stay less and feet tend to breathe better. I will have to, I don't know if I saw somebody from Switzerland is here. I have to give a shout out to this. There's a brand of sneaker that's, it's a Swiss brand. It's called On, O-N. And my son, who has PC, tried those and he said, geez, you got to try these. These are unbelievable. And I tried them. And I tell you, for me, it's I don't want to say a game changer, but it's pretty close to a game changer as far as dramatically increasing the comfort with it. It's got the rocker configuration. It's got just about the right amount of cushioning. It just redistributes the weight pressures in such a way that they're not heavily focused on one spot. So if anybody's interested in those, I have no connection to the company, to give the information. There's a website, on-running.com, and the model, and I've tried a couple of different models. The one that I find to be particularly effective is called the Cloud Swift. It's pretty good. And then one last point I'd like to make with the shoes. I think the tendency is for people, for PC, and my father was a classic example of this while he was still living. He was afraid of getting pressure on the feet, so he always would get his shoes overly sized. They'd be too big, to the point where towards the end of his life, he was wearing shoes. I could stick 2 fingers behind the end of his heel and still have room. That's how loose the shoes were. And what he didn't realize is that when you have shoes that are too big, you get a lot of movement within the shoe. You get a lot of friction within the shoe, which again can lead to blistering and worsening the lesion. So it's difficult for a lot of PC patients to have a snug fit, but you want a snugger fit where there's no movement of the foot within the shoe. So I think that's important. And the last thing, sorry to run on, I think you asked about insoles and orthotics and things like that. The right type of insole can make a dramatic difference. The wrong type of insole can make a dramatic difference in the wrong direction. So if you have access to, I think somebody has a good understanding of foot orthotics and insole materials and things like that, that would really be a tremendous help. It can be a little bit frustrating if you try to do it on your own, because there's so many things out there that can actually make it worse. But there are materials, I think, that if you match the material to the patient, you can make it a lot better. Sorry for running so long.
If they were seeing a podiatrist someplace in the US or in Europe, are there things that they should say, these are materials that we have found to be helpful? Does that help them?
Yeah, it might. I think that, yeah, I think it would. And one of the material, and I think somebody who's skilled in it would know all these materials and they would probably come to the same conclusion. but there's a material called plastizote that is pretty helpful. There's different densities of it, how it conforms to the foot, and but still supports the foot. We see a lot of diabetic patients with neuropathy in our practice, and some of the characteristics with them as far as lesion formation and reducing lesion formation and pressure and things like that are similar between PC patients and diabetic patients. And so if they mention that to the podiatrist or the doctor that they see, with the focus of redistributing pressure from the lesion spots, those materials will be pretty evident, I think, to that provider. And again, what may work great for one person may not work well for another person, because everybody's, the experience with PC is different. But I literally, if I did not have my orthotics in my shoes, I could walk 15 feet and I would have to turn around and get them. I mean, that's how dramatic the difference it makes for me.
You'll notice that there's lots of suggestions in the chat, which is wonderful. And so you can pay attention to some of the recommendations they're making there as well. That's what Dr. Bravo has also mentioned in terms of foot, the shoe selection, as well as inserts and so forth that are used to reduce the pressure on certain areas of the feet. One last area that came up in discussion are the genetics of PC, and Robin did an excellent job of introducing that concept. People have asked a little bit about predetermining whether an embryo has changes that are characteristic of PC, and there are techniques now, as Robin mentioned, that they can use to select embryos that have been looked at and do not have the mutation found in PC. That can be a very expensive procedure, and there are some challenges and so forth with that. But there are at least ways that you can look at picking children in a sense, and pick embryos that don't have that mutation. I'm trying to, if there's anything else, from the panel, any thoughts about reproductive and family aspects of PC that would be helpful? You want to take that on?
Maybe I can refer to our own experience in Paris. We've many years ago, we've performed pre-implantation diagnostic in a family, and which was successful. I mean, the baby was in the non-affected embryo where we implanted, and the baby was born healthy. And we are in the process of doing the same in collaboration with another lab from Strasbourg in the coming month. So it is a procedure, a pre-implantational diagnostic, which have been successful, at least in our hands, in one PC family. But this is, as you said, it is different from the usual prenatal diagnostic procedure, which usually do not involve in vitro fertilization, but just natural pregnancy, with the difficulty of taking the decision to stop a pregnancy if the child is predicted to be affected. So indeed, pre-implantational diagnostic is a significant progress, but in France, usually it takes, because it's a highly sophisticated procedure, which can be performed only in very specific genetic centers. For example, in France, there are less than half a dozen of them which are doing them in the entire country. And it is reimbursed by the national insurance, but there's a long waiting list. Often the couple has to wait for 1 year. And also the procedure is far from being a guarantee of success. There's an average of around 20% of success from the start of the procedure. But it's a very elegant and human procedure. Yeah.
Thanks, Alain. It is available, and I guess that's the thing we would say is available, but there are some challenges, both getting to the right places and also once the process itself is also challenging. So that possible, but still a work in progress. We talked a little bit about modification of the gene that produces PC. Roger Casper, I hope Roger is still on the call somewhere. And Roger has done a lot of work looking at modifying DNA to really solve the original problem of what do you mutation produces changes in keratin, or the things we can do to alter the DNA. There's people have talked about the CRISPR technique for changing the genes in DNA. But Roger, if you're on, do you want to talk a little bit about what has been looked at and what can be done and what the future holds for that?
Thanks, Dave. I can. I'm actually taxiing on a runway for takeoff, so I'm going to get in trouble.
I'm sorry we didn't get
Talk fast, Roger. Talk fast.
I'll talk really fast. So we've made tremendous progress in some areas and very little progress in others. So the chemistry of this siRNA technology that some of you are familiar with has really grown by leaps and bounds. And there's tremendous promise there for PC and for other disorders. We're still working on different delivery technologies. Our goal is to have a topical formulation that can just be rubbed on. But I was heartened by the comments by Oprah about using botulinum toxin and all the injections that were made. And one potential approach that we could do now is to inject these siRNAs and get at the root cause of the issues with PC. But that's not an ideal situation for us. We'd much rather be able to use a fully topical version that essentially had no pain for PCers.
Safe travels, Roger. Don't get in trouble.
Okay.
Thank you.
Good luck. Sorry to be, I should have come quicker to you.
We didn't know.
In our panel, we have a number of experts in terms of what's happening in terms of genetic modifications. Adele or Alain or Ellie or any of those, any thoughts in terms of oligonucleotides, CRISPR? Are those realistic options in terms of the future for PC?
Well, if I may answer, I think technically it's not a problem to correct the mutation in vitro in the cells in culture. This is easy with the new CRISPR-Cas9 technology or with base editing. But the problem, as Roger Casper always says, is the delivery of the system, which means how are we going to correct the cells in vivo, and that's difficult. So I think until the day where we will have an effective way to correct the cells in vivo, this procedure will be fantastic. At the moment, we can do it only in vitro in the lab. And delivering the CRISPR-Cas tools into the skin is quite challenging at the moment. We would need to find a fantastic formulation which will bring these molecules into the cells, which at the moment they don't exist.
Other comments? We had an interesting question from one of the participants that sent this in earlier. They said, how is it best to establish a relationship with a physician not familiar with PC? So you're going to a new doctor who's never heard of PC. How do we introduce that, or how do you help educate that physician in terms of what the disorder is? We have Benjamin Names, who is a physician and researcher in Dallas, I think, at UT Southwestern. And do you want to talk about that? Because you've recently had an exposure with a new patient with PC. And talk about what might be helpful.
Sure. I mean, I think that the PC project is a fantastic resource. The website has excellent resources for clinicians as well as for patients. And I think directing directing your care provider there is can be very helpful. Certainly, if you know your diagnosis, you're already a couple steps ahead of the game. While it's true that this is a very, very rare condition and many medical providers may not be aware of it, I think most people are going to want to learn and do the best that they can to help. I think many dermatologists will be aware of PC, or at least have read about it. I think the challenge, certainly in the United States, is if you go in the community to a dermatology clinic, you may not be seeing a dermatologist. You may be seeing somebody who has more experience with cosmetic procedures. So it's a little bit of trying to find the right person to work with. But I think there are great resources out there, and I think it's if you just tell them what's going on, and I think they'll do the best they can to help.
Excellent. I think that the finding ways to educate them is very helpful, and the website, and particularly as we get this new website up, I think would be a great way to introduce that if the physician is interested. And that's been the challenge, is getting somebody who's interested enough to go research it and go learn about it. Because a physician that will do that, then it's going to be a great help to you as an individual with this condition. So you have to find a physician that's willing to learn. One other thought while you're on the monitor there, there's a condition called follicular hyperkeratosis that occurs most commonly in younger individuals with PC and around the joints, like around the knees and something around the waist. Do you have any thoughts for best ways to manage follicular hyperkeratosis? What kind of things you may suggest?
I think that's very difficult. I think that that's a finding that can show up in a number of, in PC, but also in other patients. There are different moisturizers and emollients that may be helpful for some patients, creams with urea or
lactic acid.
Lactic acid or amlactin is a common name for it in the US. But I think sometimes the response it depends on the patient, and it's doesn't always work perfectly for everybody. So unfortunately, there's a fair amount of trial and error. But while it may not be possible to get rid of it completely, I think, like many of the other symptoms in PC, there are tools for managing it, and that can make it a little bit easier to work with.
Two aspects. It does seem to get better with time, and then keratolytic agents that Dr. Names mentioned, urea, salicylic acid, lactic acid, and so forth, may be mildly helpful. The question related to an area that there was some friction, and so hydrating that and then using things to reduce that keratin surface seemed to be helpful in that condition. Jan, that's really the sum of the questions that were submitted. There may be lots of other questions now that we've reached that point, but I'll turn it back to you and let you go from there.
Oh, you're man, I was just going to say, how many more questions? We're doing great. Everybody, are you getting your questions answered? We tried to give the top priority to the ones that gave them in the pre-registration, just because we know this is what happens. Thank you. And if you have them, keep sending them. And I just put also on the Facebook chat, I mean, I hate to just say that, but there's so many good suggestions from patients out there on how to care. And earlier I talked about our new website. We're hoping to gather some of that data. I shouldn't say data, but some of the information that is on that chat that's just patient suggestions, and put it on our website, because even though we don't necessarily call it medical advice, you guys have come up with a lot of good tricks along the way on how to manage your care. And there's a lot of commonality. So look forward to that. With that, I just want to say thank you to our panel. I think we probably could have actually answered questions for a long, long time. But if you are a physician or a researcher with us on our team, thank you, thank you, thank you. You're here on a Saturday, and just folks, just know that these guys have sacrificed your day for us. And